Good morning, everyone. You're all very welcome to St. Patrick's Mental Health Services annual Founders Day conference, which is held every year to recognise and continue the pioneering legacy of the founder of St. Patrick's Mental Health Services, Jonathan Swift. For this year's conference, we're exploring the mental health of migrants and refugees. So throughout the day, we'll be examining the needs of migrants and refugees, the most appropriate responses, and crucially, we'll hear the lived experience and associated mental health impacts of migrants and refugees in Ireland. Following our keynote address, we'll have a short break, and then we'll have two sessions, each of which will end in a panel discussion. So you'll have a number of opportunities to ask questions. Shortly, Professor Paul Fearon, Medical Director of St. Patrick's, will formally introduce today's event. Then Minister for Older People and Mental Health, Mary Butler TD, who has joined us to deliver an opening address for our Founders Day conference over the last number of years, was unfortunately unavailable to attend today, but she has shared a pre-recorded message, and we'll show you that in a little while. Then Professor Craig Moran will deliver our keynote address, exploring the prevalence of mental health difficulties among migrant populations and highlighting key research in the area. Before I hand over to Professor Fearon to get us underway, I just have a couple of housekeeping things to go through. So anybody with accessibility requirements, you can turn on closed captions just by clicking the live transcript function in your Zoom window. If you have any questions for our speakers, you can pop them in the Q&A box, which you'll see at the bottom of our screens, and we'll try to get through those during the panel discussions. Now, if your question is for a particular speaker, please mention that in the text so that I can direct it to the appropriate person. CPD certificates from the Psychological Society of Ireland, the Irish College of General Practitioners, and the Irish Association of Counselling and Psychotherapy will automatically be sent to attendees who registered for CPD when signing up to today's conference. General certificates of attendance will also be issued to anyone who's requested them, but you may need to leave up to about 6 weeks for receipt of those. And finally, you can follow along with the conference on our social media channels, which I think the team will pop into the Q&A box. So this year we've kept it just to the Q&A box rather than the chat and Q&A, because in the past sometimes things can get lost between the two. So we'll just focus in the one space for today. Okay, let's begin. I'm going to hand you over to Medical Director at St. Patrick's Mental Health Services. Good morning, Professor Paul Fearon.
Thank you very much, Jan, for that welcome, and welcome everybody to this year's Founders Day event. I'm really delighted you can all attend. We usually meet up the Founders Day committee about 6 months before the event, and one of the first decisions to make is what the theme for the year is going to be. And at the time, we felt that this particular theme was timely, but of course, both events, both internationally and nationally, have kind of caught up with us in that time, unfortunately. So I think it's particularly timely in light of recent events in Gaza, but also in Dublin, that we acknowledge the challenges faced by migrants living in Ireland, and particularly over the last number of weeks, which undoubtedly are going to impact their mental health and well-being. At St. Patrick's Mental Health Services, we try everything we do and say, we try to ground it in a human rights-based approach. And we're very strong believers that everybody has the right to live a mentally healthy life. We also try again to ground what we say and do based on robust evidence rather than individual speculation. And it's in that spirit, I think, that we're holding today's event. We're delighted to have such a diverse range of speakers, and we're joined today by experts based in Ireland, the United Kingdom and Switzerland. And I'm also particularly delighted to welcome Safa Kharita and Jennifer Cheaper, who both came to Ireland following journeys from Syria and Zimbabwe, respectively. Both Safa and Jennifer will share their journeys of migration, outlining their experiences and how it impacted on their mental health. It's also particularly timely that the conference also comes as the government today closes a public consultation to help inform the development of a new strategy for migrant integration in Ireland. It's reckoned today the World Health Organization estimates that there are some 1 billion migrants globally. That's about 1 in 8 of the global population. This includes 281 million international migrants and 82.4 million forcibly displaced, of which about 26.4 million are refugees and 4.1 million are asylum seekers. We know that the experience of migration is a key determinant of health and well-being. Refugees and migrants remain among the most vulnerable members of society and are often faced with challenges such as xenophobia, discrimination, and unequal access to healthcare. Refugees, asylum seekers, and migrants are highlighted as being in need of special protection and support, and evidence shows that migrants are exposed to various stress factors which affect their mental health and well-being, both before, during, and after the migration journey and during the subsequent settlement and integration. And research has shown that the prevalence of a range of mental health difficulties tends to be higher among migrants and refugees than their host populations. And our keynote speaker, Craig Morgan, will address some of these issues. So today's conference is focused on identifying the mental health needs of migrants, many of whom will have complex psychological needs. It'll also look at the appropriate responses to those needs so that healthcare professionals can be supported in becoming more inclusive of their experience of migrants in their practice. So I'd like now to turn to welcoming the Minister of State for Older People and Mental Health, Mary Butler, TD. As Jan has mentioned, she was unable to join us live today, but she's very kindly provided an opening address that we're delighted to share with you now. This is the 4th consecutive year that Minister Butler has contributed to our conference, and we're really grateful to her for her continued involvement. She's like a friend to the conference at this stage. So I'm going to hand over now to her opening video address. Thank you very much.
Good morning, everyone. I'm really pleased to again address the St. Patrick's Annual Founders' Day Conference. I would like to sincerely thank Professor Paul Fearn for inviting me to do so. The Founders' Day Conference theme last year was around adolescent mental health. The year before that, the Founders' Day covered human rights, mental health and the law. I have no doubt that today's event will be equally as informative and engaging, and that we can all see linkages between the themes over recent years in the context of improving mental health care in Ireland. Founders' Day presents us with a unique opportunity to reflect on the great example set by Jonathan Swift, who recognised nearly 3 centuries ago that people suffering from mental health difficulties required a specialist service to provide care, compassion and a voice for some of the most vulnerable in society. While these fundamentals have remained constant over time, our responses have, and they should always be developed to best meet evolving needs. The theme of this year's conference, the mental health of migrants and refugees, builds upon the well-established approach of inclusivity. The theme is apt as we work together to build a modern, multicultural society in a country that is open and welcoming to those who are in need, and that supports those fleeing from conflict and persecution. I wholeheartedly agree that all efforts should be made by all stakeholders in the sector to offer migrants and refugees the best possible mental health care. This needs to be reflective of the fact that many have endured difficult circumstances and often life-changing experiences before they travel to find safety. We must ensure that everyone accessing mental health care are listened to, they're respected and aided on the road to recovery. This should involve genuine consultation and meaningful input by migrants and refugees to help tailor the services they need. Like so many of our European neighbours, in recent times, Ireland has seen an increase in the numbers of those seeking refuge within our borders. As a nation, we have responded well in many respects, and this government has continued to work hard to ensure that social workers are provided to those who come to Ireland at their greatest time of need. However, it must also be recognised that recent events have highlighted some of the challenges that refugees and migrants face in this country. We should not let the actions of a small vocal minority detract from our collective responsibility to support, develop and protect a modern multicultural country that responds to the needs of all who live here. There are many reasons why people chose to migrate, and these are not always negative. Unfortunately, though, many people have to leave their homes in search of safety, a decision often forced on them by circumstances outside their control, such as violence, famine or persecution. We know that migrants and refugees are therefore vulnerable to experiencing mental health difficulties, often due to significant trauma. Regardless of the catalyst leading people to migrate, we must ensure that Ireland's mental health services are culturally sensitive to and reflective of the real mental health needs of this cohort. The Department of Health and the HSE are actively advancing a public health response for refugees arriving in Ireland, Significant funding of €50 million has been provided to underpin healthcare services for refugees in 2023, and this will be continued into next year. Central to this response is the development of migrant health teams across the CHOs of the HSE. Other innovations include training in interpretation for healthcare staff, catch-up vaccination programmes and dedicated in-reach GP clinics. Refugees can access a range of healthcare services from the HSE, including mental health, children's health, disabilities, maternity care and services for older people. This is in addition to others such as COVID-19 vaccinations, GPs, community care or hospital and emergency care. The World Health Organization is the world leader in supporting countries to make health for all, including refugees and migrants, a reality and to articulate a common vision for health and migration. One aspect of this work is the Action Plan for Refugee and Migrant Health in the World Health Organization European Region 2023 to 2030. The Refugee and Migrant Health Partnership speaks directly to one of the pillars of this plan, to explore innovative ways of working and to develop enabling partnerships to ensure universal healthcare for migrants and refugees. The Department of Health, in partnership with University of Limerick and the World Health Organization, has established a partnership for refugee and migrant health. The goal of the partnership is to support the involvement of refugees and migrants in the design and the delivery of public health policy. The partnership seeks involvement from people with lived experience of migration, civil society organisations interested in refugee and migrant health, health service planners, managers and providers, health policy makers and academics based in Ireland and members of the World Health Organization Migrant Health Programme. Minister Donnelly has allocated funding of up to €636,000 for this partnership over 4 years. While good progress has been made on developing policies, expanding services and updating our mental health legislation over recent years, my priority is to progress this. We continue to develop also a focus on person-centred care, aligned with a more human rights-based and recovery-orientated approach. When I was preparing my speech for today, I came across one line in particular on the St. Patrick's website, which reads, "Many people with mental health difficulties can wait years before seeking help." Leaving aside acknowledged capacity pressures, this simple message is so important as stigma in itself still unfortunately dissuades some people to access their mental health care they need. Events such as today contribute greatly to increasing awareness around mental health, to reducing stigma and to highlighting the needs of different groups in society. Reducing stigma and increasing awareness are core to what we all do. It is really important that we continue to build on the positive attitudinal change to mental health that has taken place over the last 20 years or so. It is all of our collective responsibility to ensure that everyone feels supported and listened to when they experience mental health difficulties. As we encourage more open dialogue about mental health, we must also simultaneously ensure that people can access timely and high quality mental health services when they need it. There are accepted challenges facing us all, particularly around increasing demand, case complexity and staffing recruitment and retention. Other impacting factors such as accommodation or cost of living pressures continue to be addressed across government. The government and I, in collaboration with the HSE and its key NGO partners, are fully committed to improving all aspects of mental health care for everyone in society. This commitment was reflected again recently in Budget 24, which will see record spending on mental health rise to almost €1.3 billion next year. This is the 4th consecutive year that an increase has been provided to support mental health services and highlights in real terms the importance the government places on this key care programme. This significant investment will enable further implementation of the short and medium term measures in our national mental health policy, sharing the vision, enhancing mental health supports across a broad continuum ranging from mental health promotion, prevention and early intervention to acute and specialist mental health service delivery. I am happy to say that good progress overall continues to be made on implementation of sharing the vision, and regular reports of this can be accessed on the Government of Ireland website. Good progress has been made too on the Mental Health Bill, which will update the Mental Health Act 2001 and on the Health Information Bill. Both of these involve significant and complex work, and I have ensured that despite many competing legislative demands on the Dáil, priority drafting continues into the current autumn session. These are only a sample of the progress being made across the breadth of mental health services. Work continues on many fronts at both national and local levels to translate additional government investment into service improvements on the ground. This includes advancing our national clinical programmes. I commend your clear commitment that all people, including migrants and refugees, are empowered and given the opportunity to protect their mental health. I also commend and fully support your partnership and approach in this and in so many other ways. And in this context, I would like to especially thank Paul Gilligan and his team for their ongoing collaborative approach. Before I conclude, I would just like to say that Dr. Swift would once again be proud of the tradition and future vision of St. Patrick's to promote the highest quality of care, well-being, awareness and advocacy. Thank you again for the invitation to open the 2023 Founders Day Conference, and I wish you all the very best for the future. Gorv Mila Mahabwif Guler.
Thank you very much, Minister, for that address. Even though you're not here in person, we really do appreciate that. Well, I'm now going to move on to welcome our keynote speaker this year, and I'm particularly delighted to welcome my old colleague, Craig Morgan. I feel almost like I'm basking unfairly in his the reflected glow of Craig's success over the years. The reason I'm mentioning that is Craig and I worked together in London at the Institute of Psychiatry for about 12 years, from 96 to 2008, I think. I mean, he's just been a wonderful colleague both during and even since those times. In terms of his biography, I mean, Craig is Professor of Social Epidemiology and at the Institute of Psychiatry, Psychology and Neuroscience at King's College London. He's also the co-founder and co-director of the cross-faculty ESRC Centre for Society and Mental Health. His research is particularly focused on social and cultural influences on the onset, course and outcome of mental disorders, particularly during adolescence. And he leads on several multi-country programs on these topics, and it's funded by all the big funders, basically the MRC, the Wellcome Trust, the ESRC and the European Union. He's published over 250 academic papers. He's edited 3 books. He leads the Lancet Psychiatry Commission on Psychoses in Global Context. And as if that wasn't enough, he's also the editor-in-chief of the journal Social Psychiatry and Psychiatric Epidemiology, and he's an honorary professor at the University of Hong Kong. It's always interesting, you know, when you talk about somebody so successful is why. And I think in Craig's case, I think there are 2. I mean, I'm not restricting to 2, but there are 2 particular reasons why Craig has enjoyed such well-deserved success. First of all, he just asks the right questions very scientifically, and he'll drill down into what the real issue is, and he won't be satisfied. He won't let go of that until he's both formulated the right question and then also doggedly looked for how to find the answer to that question. And these questions, I mean, not only are they scientifically rigid, but well thought through, but also they tend to be relevant questions. So it's not just good quality science that may have no application. His research tends to have real world application and advances our knowledge. And the other thing which I think is equally important is that Craig is a great colleague. I really regard those years in London as golden years in many ways, and that was partly due to the close colleagues I had there, Craig being central among them. He's very supportive both of colleagues and particularly of young researchers up and coming. He's very generous with his time and his expertise, and I've no doubt that that's the reason he has such wonderful collaborations globally, and also has such a great team around him. I should also point out that Craig is also an avid fan of Manchester United and Bruce Springsteen. I'm only mentioning this to point out that nobody's entirely perfect in this life, but there you go. So I'll hand over to you, Craig, now, and thank you so much for presenting this year's keynote talk. Thank you.
Thanks very much, Paul. I'm not entirely sure I can follow that. That's really kind and really, really appreciate it. It's actually 25 years ago this year that I started at the Institute of Psychiatry and met Paul, and I guess much of what I talk about today will be built on work that stems from that period. So very pleased, very grateful to have the opportunity to join and to talk at this event. It's always a real privilege to be asked to do something like this. I'm just going to try then to share my screen and start the presentation, and hopefully everyone is able to see that. And let me just start this. Okay, great. So hopefully you can all see, you can see this. This topic is of course timely, and the Minister's address underscored that migration is a global phenomenon. It impacts many people, it impacts societies broadly, and it's growing. And to begin here and with this, there are around about, at least in 2020, around about 280 million people worldwide, globally, who are migrants. The numbers of refugees, asylum seekers is around about 36 million, and again is growing. And in particular, many people who migrate, many people who seek refuge and seek asylum are young people, who are children. And the impacts of migration are of course global, but they're also different across different contexts and in different places. And what this slide simply shows is the proportions of people in each country who are migrants. And you can see from this, hopefully, that the proportions vary. What you can't see from this is that, according to these figures, around about 20% of the population of Ireland excuse me, are classified as migrants. And of course, large-scale migration underpins and underlies increasing diversity in societies, and the increasing diversity tends also to be clustered, and to be clustered in particular places, and in particular in cities. And this slide just shows this in relation to England, and the darker shadings representing greater diversity according to a measure of diversity. And here you can see, particularly for London, high levels of diversity in London. And a lot of what I might talk about will relate to, in particular, to Lambeth and Southwark in South London, which is where the Institute of Psychiatry is, whereas a lot of the work that we've done with Paul, has been conducted in that part of London. And hopefully you can see that there is a huge amount of diversity. And I would imagine as well, although you will all obviously know much more about this than I do, that in Dublin and in Ireland, that it's in Dublin where there's greatest diversity. And this has all manner of implications for societies. And this includes implications for mental health and for mental health services. The nature, the extent of problems, the background risks, outcomes, the interactions with services, engagement with services, and responses to interventions and so on will all vary by cultural, social, ethnic group, and so on. And communication and engagement will be impacted by cultural and linguistic differences, posing several challenges for mental health services. And so in this talk, what I want to do is I want to consider the nature of these variations and challenges, focusing in particular on psychoses. And the focus on psychoses is for a few reasons. It reflects the focus of much of the work that I've been involved in. It also reflects the fact that much of the research that's been conducted on migrant and minority ethnic populations in relation to mental health has been on psychosis, not wholly by any stretch, but a large proportion of work has been on psychosis. But also the work on psychosis does have and does enable us to draw out some general points and general observations that are relevant to understanding the impacts of migration, asylum, refugee status, and so on mental health. So what I'll try to do while focusing on psychosis is also to draw out some general points and general lessons that can be learned for mental health in relation to the wider topic of migration and mental health. So what I want to cover in the time that's available is to briefly provide some context by talking about migration, ethnicity and mental health in general. As I've mentioned, then to focus on psychosis and talk a little bit about variations in risks for psychosis amongst different populations. Then to extend that and then to broaden out a little bit, talk more broadly about the nature of psychoses and risks for psychosis and how these have changed over the past 25 years and what that might tell us about why there are variations in rates of psychosis and then ultimately why there are variations in rates of mental health problems across different social, cultural and ethnic groups. And then to extend that to consider what that might mean in terms of how mental health problems present, the kinds of presenting symptoms that people with various disorders, but from different backgrounds present with, what that means in relation to outcomes, and to reflect on the implications of this for services. And so there's a lot of information that I want to cover, a lot of points that I want to try to make. So hopefully it'll be possible to do this in the time, and there'll be some general learnings and some general lessons that is possible to take from this. It's important, I think, at this point, just to make a note about terminology and language. So in talking about migrants, ethnic or minoritized groups, I think there are several risks that we need to be mindful of and attuned to. There is a risk of othering people. There is a risk of obscuring the vast differences that there are within these broad categories, the vast diversity that there is within these broad categories. There's a risk of giving primacy, and I style this as a risk. There's a risk of giving primacy to some aspects of people's identity and culture, and obscuring and ignoring potentially some of the structural and social determinants that might underlie some of these variations, some of the influences that we see. And a risk also of ignoring other important characteristics, and the fact that many of the kinds of challenges that we that I'll talk about occur at the intersections of multiple identities of migration, ethnicity, but also gender, social class, age, and other characteristics. So it's important to reflect on that and to note that. To a certain extent, what I present is constrained by the terminologies and the categorizations and groupings that have been used in research. And of course, our approach to these things varies and changes continually. So it's just, I think, important to note before moving into this literature that these kinds of caveats and limitations are important to bear in mind in reflecting on what the research currently tells us. So what I want to do is then begin broadly. The overall picture is not straightforward. It's complex, and you might expect that given the diversity that there is within this kind of broad category of migrant, refugees, minority ethnic groups, and so on. And so we would expect there to be variations and differences across populations and groups and over time. Just beginning with research on minority ethnic populations, rather than specifically on migrants, but beginning more with minority ethnic populations. Much of the research that there has been on common mental disorders, depression, anxiety, and so on, has been really quite mixed, and the evidence has not been overwhelming that there are higher levels of these types of difficulties and challenges amongst people from minoritized ethnic populations. That there are variations, but in general, not strong evidence of huge differences. And here's one of the kind of key points that I want to emphasize today. There are indicators that this may well be changing. And so what I want to do then in relation to that is just talk to this slide, which shows data from the adult psychiatric morbidity surveys that have been conducted at various time points over the past 20 years or so in the UK. This is showing data combined from the 2007 and 2014 psychiatric morbidity survey, around about 14,000 people. And a couple of things that I want to note from this, which are potentially interesting. One is that what you do see is that there is some indications that the levels of, in this instance, common mental disorders are higher amongst some Black populations. And so around about 22% compared with about 16% in white British. So suggestions that this is a changing pattern from what's previously been the case. But I think most importantly, and more importantly possibly, is the lighter shaded columns, which show the proportions of people who are receiving treatment or accessing some form of mental health care or mental health support. And hopefully what you can see fairly clearly from this is that there is a big disparity between the white British group and other ethnic groups in relation to those who are receiving treatment. And this is interesting and important from a number of angles. Of course, it's important because it means that there are large numbers of people who have needs, but whose needs, at least in relation to receiving mental health care and support, are not being met. But it's also interesting to think about what the implications are and the effects of these are over time. And it's possible, and I want you to kind of bear this in mind as we go through this, it's possible that untreated symptoms, experiences of anxiety, depression, and so on may ultimately over time crystallize into more persistent and more severe problems, and possibly into some of the kinds of symptoms and experiences that might characterize more severe mental disorders like psychosis. So something to bear in mind as we go through this. Just to kind of flesh this out a little bit, and then to now focus in on childhood and adolescence. I hesitated in showing this slide because it's not immediately clear, and these charts are quite difficult to read. So just to explain a little bit, this is from a study that we've conducted over the past 5 years in South London, which is a study of around about 4,000 adolescents aged 11 to 16 who we followed over multiple time points over the past 5 years, at least 6 time points. And it's showing data that tries to capture trajectories of mental distress over this time period. It may not be familiar to you all in Ireland, but school years 7, 8, 9, 10, and 11 are essentially the first, second, third, fourth, fifth year of high school or secondary school. So people aged 11 to 16. And a couple of points that I wanted to sort of emphasize from this. Firstly, I'm hoping that what you can see from the fact that these lines overlap and that there's no, that reading the patterns is not immediately obvious, is that, again, it's a mixed picture. Secondly, that there are differences by type of problem. So if you look at the third box, which specifically relates to externalizing problems, that's where we see the most clear differences by ethnic groups. So the starting point for Black Caribbean, mixed Black-white groups is higher in terms of levels of distress. And while for all groups, there's a decline over time, or at least a stability over time, those disparities tend to persist. And so it's important to consider the type of problem when looking at and working with people from different ethnic groups. And then the final thing is, again, to emphasize that needs change over time. I think there is a general sort of tendency in research for us to try to find generalizable universal findings. And I think what much of the research we know about mental health tells us is that, in fact, that's simply not true, that there are variations by place, by group, and there are variations over time, such that heterogeneity and variation is the norm. And what we need to be generating to provide useful knowledge for services is locally grounded information, locally grounded knowledge that we can use to address the needs of the populations that particular local services serve. And this is really just to kind of underscore or reintroduce that point. And then just to finally finish with this sort of broad brush overview, if we turn to and think about refugees and asylum seekers, then I think the picture is somewhat clearer, that there are, across a range of different mental health problems, much higher levels of mental distress amongst people who are refugees and asylum seekers. And as the address from the Minister made absolutely clear, I think this is not surprising. What you see here is findings from a meta-analysis of 26 studies, finding around about a third of people in these samples, a third of refugees, asylum seekers in these samples experience PTSD, around a third experience depression. And of course, again, this is not surprising given that many of these people will be fleeing war, persecution, and trauma. And in the UK, at least, when arriving in receiving countries, often experience and encounter hostility, which is compounded by some of the rhetoric of our politicians who have a tendency to stoke fear by demonizing asylum seekers. It's certainly a narrative that's been dominant over the past few years in the UK. And this is then the context in which mental health services are tasked with providing care for people from these populations. And one point I think to consider in relation to this when it comes to the working with and treating people from these populations is that the experience of many the experience of many of public institutions will be negative, and consequently have fostered a sense of fear and distrust and mistrust of any kind of public institutions and services. And that's the kind of, I guess, context in which it's important to consider that many of the people who present to services will be presenting against that background. So with that kind of broad sort of overview, I want to now turn to psychosis. And I've mentioned part of the reason for this is that there is just a lot and a large body of research on this, and there's research that we, myself, Paul, have been involved in over a number of years. And I want to start actually with work that Paul led on when we began this work in South London. This is from a study called the ESOP study. It's a study of first episode psychosis where we're able to estimate rates, incidence rates of psychosis in different populations in 3 centres in the UK, in London, Nottingham and Bristol. And as part of the analyses of this data, what Paul found was that the rates of psychosis amongst the Black Caribbean and the Black African populations were substantially higher than amongst the white British population. Now, there are many, many aspects to this. And a question that runs through all of this and has done so for the past 25 years and more is a question of whether these variations reflect real differences or whether they're a function or a consequence of the ways in which we measure and diagnose people from different populations. Now, I'm going to sidestep that issue for now, but can come back to it if that's something that it would be useful and important to pick up. But the things that I want to kind of highlight, and again, embracing this and focusing on this point about heterogeneity and variation, is that there isn't a single migrant effect here. Often in the literature, particularly when people do meta-analyses and so on, it creates this spurious impression that there is a single effect that relates to all migrant populations. In relation to psychosis, that's simply not the case. You can see already here that there is a difference between the Black Caribbean and Black African group. It's not shown here, but the rates of psychosis amongst Asian populations in the UK were lower than they were for the Black African and Black Caribbean group. And this is underscored by a more recent study that we did across 16 sites in 6 countries, 5 of which were in the UK. And while this slide might look busy and difficult to read, I think once you're orientated to it, the patterns become clear. What you see in the red bars are the rates of psychosis in migrant populations or minority populations from sub-Saharan Africa across multiple countries in the EU, Spain, Italy, France, the Netherlands, and the UK, and that those rates are higher than other migrant and minority populations. But not only that, the rates vary across country as well. So what you see, but there are some general patterns, but what you see is large amounts of variation. And of course, understanding the origins and the nature of those variations is key to understanding why it is that we see these patterns, but also key to understanding what the extent of needs are in these populations and ultimately how then to respond. And this extends also then, and to talk about this briefly, this extends to changes over time. So this is now showing data specifically for London from this EU GEI project. And again, in relation to the groups that I showed on in the ESOP study. And I'm hoping that what you can see from this is that there are some shifts and some trends over time, that the rates overall have increased, that there is a smaller difference between the white British and Caribbean population than was evident 20 years or so before, and that the rates for the Black Caribbean population, in terms at least of the relative rates, are fairly consistent. Now, it may be that this reflects methodological differences in the ways that studies are done over time and so on and so on. But it's also possible, and I think at the very least likely to be both, it's very possible equally that there's variation. And that's important, I think, to understand, because again, these the needs of populations are not fixed in time. They change and they morph, and they and there is a need for services to understand, to reflect, and to adapt to those sort of changing needs over time. And then just to finish on this part in relation to refugees and asylum seekers, this just shows findings from a couple of studies, one in Canada, one in Sweden, using different types of data to try to quantify the rates of psychosis in more recent refugee and migrant populations. And I'm hoping that what you can see from this is that in both studies, the highest relative rates are for refugee populations of psychoses. In Canada, and this again is interesting in terms of variation, and are assuming that there is not a generalizable universal effect. In Canada, there doesn't appear to be an effect for non-refugee migrants in terms of higher rates of psychosis. So quite marked variations across the populations, but a suggestion that a particularly high levels of psychosis and high rates of need amongst refugee populations. Interesting to think why, interesting to think about this in relation to the high levels of PTSD, interesting to think about this in terms of what it might ultimately tell us, not just about mental health problems in migrant and refugee populations, but what it might tell us also about the nature of psychoses, and something that I'm now going to turn to, because I think to broaden this out a little bit, our understanding of the nature of psychoses and of the causes of psychoses have changed over time. So over the past 20 years or so, there have been a number of trends, a number of changes in the ways that we understand psychosis. And I just want to highlight two of these, which I think are particularly relevant to understanding and thinking about how we work with people from migrant and minority ethnic populations. The first is that there's been a lot of research that's extended beyond clinics and beyond mental health services to look at what have been referred to as psychotic experiences, low-level anomalous experiences in general population samples. And it turns out that things like fleeting hallucinations, low-level suspiciousness and paranoia and so on are really quite common in populations. And what that's done is it's given rise to, or at least given renewed interest in continuum models of psychosis, in which there is a sort of distribution in the population of these types of experiences that vary in terms of frequency, severity, and persistence, such that disorder then, psychotic disorder, is the extreme end of this continuum. And that you see this sort of the kind of movement backwards and forwards across this continuum. And if that's the case, if this model works, then in situations where you find that there are high levels of psychotic disorder in some populations, if this model works, you would expect that that's a reflection of higher levels of these, or a higher frequency of low-level psychotic experiences in general population samples, as if there's a kind of rightward shift in the whole population distribution of these types of experiences. And there is some evidence to suggest that this is indeed the case. And this is showing findings from a study that we did, a community-based survey that we did in South London a little while ago, where we found really quite high levels of low-level psychotic experiences. I should emphasize at this point, when I refer to these psychotic experiences, you see in brackets anomalous experiences. This reflects my own sort of uncertainty about what these types of experiences really reflect. But to leave that to one side for a second, when you look at this in general populations, you nonetheless find high levels. And in this study in South London, the same areas where we've done the studies of psychotic disorder, what we found was there's around about 18% who report these experiences when questioned, and that there are variations by ethnic group, and that these variations are quite similar to the sorts of variations that we see in relation to psychotic disorder, which, and of course, conscious that this is tentative, but variations that are in line with what we would expect if that continuum model of psychosis is right. So that's one way in which I think our ideas about psychosis have shifted over the past 20 years or so, and one way in which the research that has been done, particularly on minority ethnic populations, has served to contribute to that shift in our understanding of the nature of psychoses. The second thing that I want to come on to and to spend a little bit of time talking about is the extent to which our understanding of the risks for psychosis has changed over time, such that we now have a much broader range of risks that we consider to be important in relation to psychosis. And these extend beyond genetic, biological, neurodevelopmental risks to incorporate and include a wide range of social risks. And over the past 20 years, been a large amount of research showing and finding, reporting on a whole range of social risks. Now that also creates and poses questions, because if, broadly speaking, social risks, adversity, and so on are associated with psychosis and increased risk of psychosis, then it begs a number of questions. If that's the case, why, given that these kinds of adversities are so common, why do so few people develop psychosis? That relates then to questions of mechanisms and moderators and modifiers and so on. So what might be the mediating mechanisms and the modifying factors that shape why it is that some people and not others develop psychoses? All these kinds of adversities, and if you think about this even in relation to migration and asylum seeking and so on, the kinds of experiences that are common in these groups relate to a whole range of mental health outcomes. So if you think about trauma and adversity and so on, these increase risk for probably every mental health problem that we can think of. So it begs the question of, is there what is the specificity, or is there any specificity in relation to psychosis, and how and in what ways do these relate to psychosis? And so I want to kind of address those things in two ways. Firstly, and I'm going to come back to this, but this slide is to emphasize the extent to which at first presentation to services, even during and at the point of the first episode of psychosis, people still present against a background of high levels of social disadvantage, isolation, and social exclusion. And this is just using a fairly crude set of measures that shows that people at first presentation of higher levels of employment, live in rented accommodations that indicate a kind of household income, tend to be more isolated, poor educational background or relatively poor educational background, and so on. And that there is a linear association, so that the more of these that are present, the greater the likelihood that it is that someone presents with psychosis. At this point, I'm not making any comment or suggestion in relation to how these might contribute to onset of psychosis, but I think it tells us something about the contexts within which people present. But there's been a lot of interest, a particular interest in early childhood adversity, in particular early abuse in relation to psychosis. And this slide shows data from a study that we did kind of in between the ESOP study and more recent work that we've been doing with adolescents, which was very much specifically focused on questions of kind of adversity in childhood and adversities in adulthood. And the difference in this study from many studies that have gone before is that we paid particular attention not just to the presence or absence of these experiences, but also to the timing, the duration, the frequency, and severity. And in doing that, some interesting observations emerged, which I think are particularly interesting and relevant in terms of trying to understand what it might be that's specific about experiences of adversity that might relate to psychosis. So just to try to build this argument up a little bit, and then to relate it back to questions around migration, ethnicity, and so on. So firstly, what you see here is taking a typical approach where they've got 5 indicators of early childhood adversity, household discord, essentially tensions and arguments between parents in a household during childhood, bullying, psychological abuse, physical abuse, and sexual abuse. And each of these associated with something like a 1.5 to 4-fold increased odds of psychosis in a kind of case control context. And I'm going to just show one example of this. There are also other interesting aspects of like duration, age, and so on. But if you then begin to look at this in more detail in terms of severity of exposure, then interesting patterns emerge. I'm not going to go into too much detail about the definitions of each of these elements, but to note 2 things. Firstly, in relation to household discord, we specifically separated out domestic violence from other forms of household discord. And so the violence at the far end of the slide relates to the occurrence of domestic violence in the household, well, children during childhood. And the other forms of marked adversity at the more severe end, these forms of adversity always include violence. And so to give an example, bullying that is rated as marked in terms of its severity is bullying that has involved physical assault and violence. And I'm hoping that what you can see is that for each of these, the greatest likelihood of psychosis occurs for those who have been exposed to the most severe forms of abuse, the forms of abuse that in particular involve violence and threat. And I just want to extend this a little bit further and show another set of analyses, and a set of analyses, again, which in this graph is not immediately clear, but let me just kind of talk through what's happening here. So one of the kind of challenges with all of these sorts of adversities that they tend to cluster and they tend to co-occur. And so looking at each in isolation is problematic because these things tend not to be independent. And so one way to kind of work with this and to think about this is use analyses that try to characterize and group people according to their likelihood, their probability of being exposed to a whole range of different adversities. And so what you see on this slide is a representation of the relative probabilities of being exposed to a whole range of adversities during childhood. Now, I'm not sure if you can see my pointer as I point this or use it, but if you can, then this will be clearer. If not, let me try to talk it through. So what's represented here are three groups identified through this analysis, three groups who differ in terms of their probability of exposure to these range of different adversities in childhood. And so this red line here represents a group with a relatively low probability of being exposed to the whole range of these different adversities. The green group is a group that is characterized by a relatively high probability of exposure to this full range of adversities. And then the third group, the group represented by the blue line, is a group that has a relatively high probability of exposure to these initial experiences here, which relate to kind of challenges at home and in school, but a relatively low probability of exposure to some of the more severe forms of abuse and so on, represented at the far end of this. And what you can do then with that analysis is when you've identified these different clusters of experience, is ask the question, is there an association between these clusterings and the likelihood of experiencing mental health problems, and in this case, experiencing psychosis? And then what you can see at the bottom right-hand corner are the odds ratios that express this. And the key thing to kind of note from this is that the highest odds are amongst those in the group with the highest probability of exposure to this full range of experiences. So it seems, or at least the case that I'm trying to kind of establish from here, is that there is something about being exposed in childhood to a whole range of negative experiences, particularly experiences that involve trauma, violence, threat, and so on, and particularly against a background of disadvantage and material disadvantage in particular. And then just to extend that into adulthood, so this is the same study, this is findings in relation to life events. There's a lot of literature on this. The more life events people experience, the greater their risk of, or the greater the odds of subsequent developing psychosis. But if any of you remember the work by George Brown and Tyrrell Harris on depression, as part of that work, what they found is that there was a particular increase in risk for depression amongst people who experience particular types of life events that involve humiliation, entrapment, and loss. And what they hypothesized was that if that's the case for depression, then for psychosis, maybe there is some specificity for the type of experience. And they hypothesized from that it was experiences that involved elements of threat, what they called intrusiveness, which would be more linked to psychosis. And so what we were able to do in this study is essentially address that question. And so when we looked at this in terms of, and in relation to non-intrusive versus intrusive events, we found, and again, this is one study, and so there's a limit to what you can infer from a single study for sure. But what we found was broadly in line with that the greatest odds of psychosis were evident for those who reported experiences of or intrusive threatening experiences. And there is a body of literature that's beginning to emerge that suggests there may well be some specificity around the type of experiences that relate to psychosis, and that it might be that it's something to do particularly with experiences of threat, violence, and trauma. And of course, discrimination, to bring it now back to, or to begin to bring it back now to consideration of the experiences that people in migrant minority ethnic populations have. Experiences of discrimination are experiences that involve high levels of threat. And what you see in this slide is just a couple of studies which have approached this from different angles, but the sum of it is that both suggest that those who are exposed to more discrimination have a higher likelihood of experiencing psychosis. And I want to draw attention in particular, although I acknowledge that this is somewhat tentative, but in particular to the findings from the study on the right-hand side, which found that the highest risk, or the highest odds rather, were amongst those who reported being racially, physically assaulted, which again ties in with this sort of idea that maybe this is something to do with the contexts of threat, high levels of threat and violence. And then to extend this just a bit further and to be more specific, this is a study from the US, which is looking at psychotic experiences, and looking at this in urban and rural settings, but asking the question around the associations between these types of experiences and criminal victimization. And what's interesting from this study is that they found that there was a particular association with being a victim of crime and experiences of or psychotic-like experiences of feeling persecuted, ideas of reference, and so on. And of course, that's kind of interesting in one sense, but I think more compelling, and just to very briefly talk about this, more compelling is this study that a colleague at the Institute of Psychiatry, Charlotte Gay Anderson, conducted as part of our study of adolescence in South London, in which what she did was use virtual reality to assess experiences of paranoia and suspiciousness and the extent to which they relate to background, past experiences of threat, and so on. And the way that this works is that you create a kind of virtual environment that young people can navigate using virtual reality, and they can interact with the avatars in the virtual reality scenario. And in this instance, the interactions were fairly neutral. So there was nothing other than people approaching others, engaging in conversation, and so on. And then after the young people have been in that scenario, then they're asked questions about their interpretations of those interactions. And the interesting thing about this is that it's possible in that context to look at the extent to which the interpretations of the interactions were characterized by ideas of reference and suspiciousness and so on. And I'm hoping that what you can see from this is that there's variations in the interpretations according to background experiences of life events. And so those who previously had experienced and reported experiencing threatening life events were more likely to interpret neutral interactions within a kind of more paranoid or suspicious framing, which I think provides interesting and potentially compelling evidence about something, not just about the extent to which these types of experiences relate to psychosis, but also the extent to which they relate to specific symptoms and experiences of psychosis. And then to bring that back to psychotic disorders, here is a slide showing data from the ESOP study. It's data that we never published, and I think it's a shame that we never published this. But what it essentially shows is that positive symptoms are more common amongst the minority ethnic groups in the ESOP study, both the presence and the severity of positive symptoms. This is hallucinations, delusions, and so on. But in particular, that there was a higher level of delusions of reference and persecution and of non-affective auditory hallucinations in those groups, the Black Caribbean and Black African groups, that have higher rates of psychosis overall. And this has been replicated in the EU GI study. This is presented differently, but what these lines represent within this hexagon is that the closer they are to each of these sort of symptom domains, the more of those symptoms that are present. And I'm hoping that what's most obvious and apparent from this is that it's in the North African and the Black populations here where you have the highest level of positive symptoms. So I guess what I'm trying to and have tried to convey from this is the idea that the higher levels that we see in some populations of psychoses may reflect different contexts of risk, contexts of risk that are characterized by higher levels of experiences of adversity in general, but in particular, higher levels of violence, hostility, and discrimination. And I want to finish and to draw this all together by very quickly and very briefly considering this in relation to outcomes, because it seems, and this I think is a really important point. Even if you're skeptical about the extent to which these kinds of experiences that I've talked about are etiologically relevant to and explain the variations that we see by ethnic group, what's clear is that people who present to services with a psychosis will present often against a background of high levels of past trauma, high levels of past adversities, high levels of poverty and disadvantage. And that will be particularly so for people from minority ethnic populations and from refugee populations. And it seems that these kinds of background factors might also relate to outcomes. So I'm going to go through this very quickly, but it seems, for instance, first, that there are worse outcomes, symptomatic outcomes amongst people from the same populations who have higher levels of psychosis. That's illustrated here. Again, using data from the ESOP study where we followed people over a 10-year period. But importantly, it seems that, and this is going back to that index of social exclusion that I showed earlier, it seems that those who are more excluded and isolated at the baseline have worse outcomes. And it seems, and it's not shown here, but it seems that some of the reasons why there are variations by ethnic group are accounted for by the variations at baseline in these background contextual factors. So it may well be that not only are these kinds of contexts related to onset, but they continue to have an ongoing impact in relation to outcomes. And more concerning still is that social outcomes for people with a first episode of psychosis are terrible, but they're worse even still for people from minority and ethnic populations. And again, this is kind of broadly illustrated here, and I'm kind of rushing over it because I'm very conscious of time. But what it essentially says and what it tells us is that people who experience a first episode of psychosis, that very small numbers ever sustain long-term employment over an extended period. But that's particularly so for people from minority ethnic groups and from marginalized populations. And not only that, we know that people who experience psychosis are at greater risk of also experiencing violence and other hostilities related to stigma, related to other elements. And so the kinds of background traumas that people often present with are then compounded by often compounded by further experiences of violence. And this is illustrated from one study here, which shows high levels of domestic and sexual violence against people with severe mental illness over the long term. So that many of these sorts of background contexts and factors continue and they persist throughout the course of people's illnesses and disorders. And then finally, and this is a final bit of data that I'm going to show, we know from many studies that people from minority ethnic populations in the UK have more negative pathways to and interactions with services. And what is shown in this slide is over the long term, rates of compulsory admissions to hospitals are substantially higher amongst people from Black Caribbean and Black African populations. And I raise this by way of drawing things to a bit of a close, because to try to tie this together, if it is that people from minority ethnic populations, people from migrant groups, people who are asylum seekers and refugees, if it is that they present to mental health services against a background of high levels of adversity, trauma, and so on, these types of experiences, these types of needs are likely to be the most salient, the things that matter most to them. Insofar as services respond or don't respond to these types of needs, may relate to the extent to which people from these groups see services as being relevant, and relate to the extent to which people may be willing to or otherwise engage with services. And what that suggests to me in terms of drawing implications from this is that we need to pay much more attention to the social needs, to the background experiences that many people present with when engaging and ultimately treating people from diverse populations. And that need to reorientate towards these types of needs is something that is bound to increase in contexts where there's increasing diversity, where there's increasing numbers of people from migrant and minority ethnic populations, where there's increasing numbers of refugees and so on, presenting against this background of trauma and so on. And I say that, and this is the final point, and I'm going to finish on this. And I say this in to come back to the point about culture, the structural and social determinants and so on. And I think there's a tendency, and this is not to suggest that this is not important, but there's a tendency when we think about people from other places, there's a tendency to think primarily in terms of culture. What I think a lot of this data and what a lot of these findings suggest is that we need to pay equal attention to the social needs, the social contexts, and to the histories of people who present to service, particularly if they're presenting against a history of trauma, violence, and hostility, and so on. So I'm hoping that from that, there are some general lessons, some points for discussion, some provocations, some challenges about how we understand and respond to these difficulties and challenges, and hopefully something that we can carry through for the remainder of the day. So thank you very much for your attention. Thank you again for the opportunity to share this information with you. And as I say, hopefully it's of some interest. Thank you.
Thank you, Craig. That was really, really interesting. And you'll be joining us, thankfully, for our panel discussion later. So if people have any questions they want to direct towards you, if you pop them in the Q&A box, and we'll put those to Craig a little later. I'm also just conscious there was so much rich information and data in that presentation, Craig, that, you know, to let everybody know who's attending, we will be emailing a link of the recording of today's conference. So in your own time, you can go back and focus in on any particular areas that were of interest to you in your work. So that will be going out after today's event. We've arrived at the point where it's time to top up on warm beverages and have a comfort break. So we'll be back for, we've got two wonderful speakers coming up for you after this short break. If we meet you back here at 10:35. Thanks, everybody. welcome back, everybody. I hope you all, and a special warm welcome actually to anybody who may be just joining us now at this stage of the conference. So we have two wonderful speakers coming up in this session, and Craig will also rejoin us at the end of those two speakers' presentations for a panel discussion to take your questions, which are already coming in thick and fast, and there's some great questions in there. So we look forward to that in the next wee while. Now, for many of us, we watched the war and resulting humanitarian crisis in Syria unfold through a TV screen, but our next speaker lived it and knows firsthand how fleeing one's homeland in such circumstances affects mental health. To generously share her experience, we are delighted to be joined by Safa Kharita. Good morning to you, Safa.
Good morning. So good morning, everyone. First of all, I'd like to thank you for inviting me and giving me the chance to share my experience. My name is Safa Kharita. I'm 28 years old. I'm Syrian, and I've been living in Ireland with my family for almost 6 years. As you all are aware, since the war started in Syria, many people have been forced to flee out of it, and we were not an exception. At the beginning, we refused to leave our house, and we thought it's gonna be a couple of days and everything will settle down and go back to normal. But till today, nothing neither settled down nor back to normal. To be honest, it took us years to accept what is happening because we never thought that speaking up and asking for our rights and freedom could cost us that much of loss. Between 2011 and 2014, we had been displaced inside Syria, specifically in my city of Zabadani several times, but we had been always grateful that we are at least not that far away from home. As so many people, we have been through a lot. Sleepless night, escaping bombs and close death, lack of water, lack of electricity, food, fuel, and even the basics. But those were not the reasons that made us to leave, because when you go through that, you kind of get used to it after a while, unfortunately. What made my parents made the decision that we cannot stay there anymore is not the fear of death, because we believe that we're all gonna die one day. But what made us leave is the fear from the unknown fate. During that time, and even until now, some people start to go missing or kidnapped without knowing their whereabouts. Who's responsible for their kidnapping? Are they alive or not? We started to see cases of abuse, harassment, arresting for no reason, assault, and rape, which led my parents to the decision that the best they can do to protect us is to flee. During that time, I was preparing for my Leaving Cert exam, obviously under the candlelight with all the noise from bombing and the chaos around, as I had a dream to study pharmacy at Damascus University, but that dream became impossible. At the end of 2014, we had no choice but to leave Syria and leave everything behind. Again, we thought we would be back in a short period of time, maybe days. So we didn't really take that much of our belongings with us. We only carried some pieces of clothes, and that was everything. But the days became months, and the months became years, and yet we're not back. When we left, we went to Lebanon because it's on border with my city. So it was the best available option. We lived in Lebanon for 3 years. I said it before and I'll say it again. Unfortunately, that was the worst stage of my life. And I believe that applies to every single Syrian who had ever lived there or still living there. It's so hard to survive from bloody war, leaving behind you your home, the country you were born and grew in, destroyed, and become to live in unwelcome country and society full of bullying towards you, violence and racism against you. And all of that just because you are a Syrian refugee, which is a thing we didn't choose, and we hated it more than anyone else. But again, it's not our fault. However, upon our arrival, we tried to deal with all the challenges. So my dad started a new job, and I started to pursue my education. Same goes for every other member of the family. Most of the universities in Lebanon are private, so it was impossible for me to study pharmacy there because it was too expensive and I couldn't afford it. So later, I've been told that there are some scholarships for Syrians in some of the institutions which were funded by some EU countries. And after long search, I applied and I got a place in healthcare nursing course. While I was studying, I started to work as a part-time doctor assistant. And after a while, I got a job in a hospital in intensive care unit. I had to choose my shift at night. So I used to go to work at night for 12 hours and go back home in the morning, have a quick shower, and go running to catch my classes at college. And that had been the case for more than 2 years till I graduated in 2017. But that wasn't as simple as it sounds. Neither me nor other member of the family who have been working hard had been paid our full entitlements, nor our legal salary because we are Syrian. So after the war and upon the arrival of Syrians to Lebanon, there has been made a new law that prevents Syrians from working except for some jobs like cleaning or the kind of job that obviously Lebanese don't want to do. But that didn't prevent Lebanese employers from taking in Syrian employees. Quite the opposite. So they started hiring Syrians with half wages. And if you don't like it, you can go to court and file a case against them. But again, in the law, you're not allowed to work anyway. So we knew that, but we didn't really have options. We needed jobs. We need money. We have expenses to pay, so we had to accept it whether we like it or not. During that time, my older brother had mated and traveled to Turkey looking for better life and future. My parents were very sad and depressed after my brother had left, and so do I, because family is very important in our culture and religion, obviously. It's at the top of everyone's priority list. So that was a hard part for us. But later, my brother made it to Greece and applied there for refugee resettlement program, and he had been chosen by Ireland as part of their agreement with UN. After arriving to Ireland, he has been told that he has a chance to apply for a family reunification visa for the rest of the family, which was a huge surprise for us. So he did, and after almost a year, our application had been accepted and we were approved to come to Ireland. We came to Ireland at the end of 2017, and you can't imagine the happiness that filled our hearts and souls when we arrived and met my brother. That decision had changed 7 persons' lives. When we arrived, we lived for a year in Tullamore Offaly, and we started learning English language. Later on, we moved to Dublin, and I applied for level 6 Executive Administration and English Language course in Whitehall College. I did my work experience for 2 weeks in the Irish Leinster House with Mr. Thomas Pringle, TD. Later on, I did my Cambridge English language exam, and at the end of the year, I graduated, and I was nominated as the Student of the Year. After graduating, I applied for UCD, and I had been offered a scholarship to do science and engineering international foundation year. I worked so hard, and I mean really hard. Even one time I collapsed and they had to take me to the hospital. And I did so because I know this is my chance to follow my dream, and it might be my last one. So I didn't want to miss it no matter what. And there had been challenges for sure. New country, new culture, new language, new education system, starting a new life from zero. We knew no one here back then. However, the only thing that made us feel at ease is the people. We felt welcomed. We felt surrounded with warmth and kindness, and that meant the world for us. I finished my year through COVID-19 hit with excellent results, and I applied through CAO to study science at UCD. Later, I was offered a place. I started my first year in general science, and in my second year, I did study 3 majors. They were pharmacology, neuroscience, and microbiology, with hope to specialize in pharmacology as it's very hard and competitive to be offered a place in pharmacology at UCD. I can tell you that after so many hard work, hours of study, and lots of tears, I had been offered a place in pharmacology, which is what I'm doing now, and I was thrilled. We are so grateful, and after all we have been through, I discovered that we are so resilient, and we try to keep positive and full of faith. Yet sometimes we feel guilty for the people that we left behind. We're always worried about part of the family who are still living there, as well as we missed and feel upset when we think about relatives who have been killed or went missing. Unfortunately, we never felt unworried. We had been affected so bad. We're always worried about tomorrow and what it's gonna bring with it. Like when the war started in Ukraine last year, we were worried and horrified. My mom kept thinking, what if the war gets bigger and came to Ireland? Where we will go? Who's gonna take us in? Are we gonna start everything for the third time all over again? And that kind of thoughts, as well as we were in utter shock after what happened on the 23rd of November in Dublin. We were already traumatized by the heinous crime of stabbing a teacher and 3 other children, to be surprised by the chaos and riots that followed. We were afraid to leave the house for the following 2 days. Me and my younger siblings didn't go to college on the following day, and my older brother had to close his business and stayed home to protect himself and his staff, because we felt more vulnerable than others. We know very well that this is not Ireland nor Irish people, and those are some minorities who don't represent Irish people. Ireland has been always a home for us, and it will continue to be, but we must be cautious. I'll be graduating from college next year, inshallah, and I'm hoping to do a master's degree in neuropharmacology, as I'm really interested in that field. I'd like to thank you all for your precious time and for listening to me. And again, thank you for having me.
Well, the pleasure is all ours, Safa. Thank you so much. That was so generous of you to share your experience in such an articulate way that gave us a real insight into the compounding effects of multiple layers of your experience and your family's experience. And, you know, I think it's probably, I'd be confident enough to echo the sentiments of everybody watching. You are a remarkable individual, and thank you so much for joining us today. And I'm really looking forward to chatting to you more in our panel discussion. So I hope you'll rejoin us then. Now, with Safa's experience ringing in our ears, our next speaker is going to share his experience of implementing psychosocial support interventions with refugees in low resource settings. So from the UNHCR, the Refugee Agency of the United Nations, I'd like to welcome senior mental health expert, Dr. Peter Ventervogel. Good morning, Peter.
Good morning. Can you hear me well?
Yes, perfectly.
Perfect. Thank you very much. I will soon start my presentation. Of course, I want to thank you for the invitation, but I also really want to thank Safa for your beautiful story. And actually, I want to say that one of the key messages that I want to convey today, you embodied it. And that is that refugees are not necessarily a burden or a problem, but refugees are a resource and can contribute greatly to the society once they are given opportunities to thrive and not just to survive. And I think you are a great example of how that can be done. Of course, it's because of your determination, but it's also because of the enabling environment that you found in Ireland that helped you thrive. So thank you very much. I would like to start sharing my screen now. That's always a little bit of a kind of scary moment. Let me see. Are you now able to see a screen?
Yes.
You are, and that is then probably, now probably you will see a screen without the speaker notes. Is that correct?
That is correct.
Then
Well,
I am where I want to be. So thank you very much. So my name is Peter Ventervogel. I'm working with UNHCR for the last 10 years. Before that, I worked with different NGOs. Last 25 years, always in refugee and post-conflict settings.
Peter, can I just interrupt? Sorry, it's Paul Fearon here. You're sharing your screen, but it's a black screen. We don't see any slides at the moment.
That's not really the idea.
Oh, I can see slides.
So I'm only sharing a black screen. Then I need to stop sharing and try it again. So let me do that again. Screen 2, share.
That's perfect. I think it may have been a local issue on one of the PCs, but that's perfect. We're all seeing your slides now.
You are seeing it? Okay,
yes,
good.
Yes, thank you.
Okay, great. Then that's a relief. Technique is always a bit scary still after all these years. So, okay. So I first wanted to let you know UNHCR is the mandated agency in the UNHCR to work with refugees, but also with asylum seekers or people applying for international protection. We also work with internally displaced people together with a range of other UN agencies and with stateless people and returnees. So that's our part of our mandate. And our work has become more and more important over the years. The current data are 110 million forcibly displaced people. And well, these figures are usually very abstract, but it's 1 in every 73 people. And just a decade ago, it was 1 in 167. It's a doubling of the percentage globally. We are not going in the right direction. I also want to highlight that by far most of the refugees are hosted in low and middle income countries. You see it here on the screen. Countries like Iran, Turkey, Colombia, Lebanon as well, Pakistan host very many refugees. And the burden on society in terms of additional people in the country is really of a different magnitude than in many Western countries. Now, UNHCR is active in many countries. We have lots of staff and personnel, but you will never see a UNHCR clinic anywhere. But we do work in healthcare and mental health care, but we do that through partners that we fund, which could be NGOs, but could also be governments, that we fund the government to add staff to cater for refugees in an area where there are many. So that's the background of UNHCR. I would like to focus on mental health and psychosocial support. And it's maybe important to introduce that concept, because in humanitarian work, we use the term MHPSS, quite a horrible acronym, but it's important because that term shows that we talk about any intervention that is aimed to protect and promote psychosocial well-being. Such interventions don't have to be done by health professionals or from the health sector, as well as activities to prevent and treat mental health conditions. And these are often, but not exclusively, done through the health sector. So it's that whole range of activities that includes a lot of community-based work and social work as well. Now, in our conceptualization, we use this pyramid, and I would like to introduce it very briefly and then use it as a framework for the rest of my presentation. So what is important here, I think many of you are clinical mental health professionals, and that's extremely important, that people have access to clinical mental health services. But it's only a minority of people who need those clinical services. So you see here in the pyramid, you see on the top clinical services, care by specialists. But you can also think of basic mental health care provided by non-specialists, so general practitioners, for example, which is something we focus a lot on in UNHCR. But we cannot rely on clinical services alone. There is a layer below, and we call it focused non-specialized support, which could be done by social workers, case management, could be done by actually quite a range of people, providing brief psychological interventions. I will say more about that in a minute. But still, this layer 3 and 4 are only part of the story. What is extremely important is this, what we call layer 2. How can we strengthen what communities and families can do themselves to improve their psychosocial well-being and mental health? And then lastly, there are actually lots of things that can be done by other sectors that have nothing to do with mental health. And I actually want to start with that one right now. This is a bit of a difficult picture, but it is about refugee camps. These are 2 refugee camps in the east of Sudan a few years ago, when there was a crisis from refugees coming from Ethiopia, from Tigray. And when I visited the place, there were 2 refugee camps. The left one was the newest one, and the right one was had already been established by refugees, actually almost before the humanitarian people came. And our colleagues in the shelter loved the left camp because it's well organized, everything is clear, structures are done, it's wonderful. But I had a different look at it as a mental health professional. This right picture is a little bit chaotic, but if you look well how the tents and the houses are put, it looks much more livable. It looks much more like an African village. And while my shelter colleagues dreaded the right camp because it was chaotic, from the perspective of social cohesion and from, let's say, livability, I liked the right one. And this led to many discussions with our shelter colleagues. What can you do in, for example, the built environment, in the housing that promotes mental health and well-being? Creating communal spaces, putting tents in a circle so that the children can play safely in the middle ground, etc. I have to be brief because I only have, I think, 10 minutes left. I want to go to that layer that I mentioned that is so important, what people can do themselves to improve their mental health and psychosocial well-being. And here it's not so much about services that you provide for people, that's the layer 3 and 4, but it's about creating an enabling environment so that people can do it themselves. So it's about creating social spaces, organizing community activities, perhaps something I really like doing, communal arts, where refugees, asylum seekers, and people from the host community work collectively on projects, sport, but also how you can make sure that refugees have the right information about services that they can access. Now, very, very briefly, I would like to give a 1-minute video of a refugee in Bangladesh, a Rohingya refugee, and I think you may know the Rohingya were massively displaced from Myanmar around 6 years ago. And within the camps, huge refugee camps, and the situation is not good there in Bangladesh, but within these camps, UNHCR and partners trained volunteers from the refugee community to actually help others. So this is a good example of this layer. So I will stop sharing my presentation and go to the video. Do you now see a face that is not moving, but do you see a face of a refugee?
Yes.
Wonderful. And I hope now you will also hear him. This is Arafat Uddin, who is a refugee volunteer this is a video from 2019. He had been in the camp for 1-2 years and became a volunteer, and he tells what he has learned about psychosocial work. Let's have a look. Can you hear him?
Yes.
এই ক্যাম্পের মধ্যে হবে তো আসন হঠাৎ তো নাইশন এখন যদি হইতো না আরে
এটা সে বর্মাত থাকিতাম বর্মাতি 30 অগস্ট 2017 আমাদের আসি এটা এখন থাকি দে 2 বছর 4 মাসে
তো ওই কমিউনিটি সাইকোসোশ্যাল ভলান্টিয়ার আমগান করতে অনেকেই কি শিখি পাইছো না তুমি কি মনে হয়
আর আছে কমিউনিটি সাইকোসোশ্যাল ভলান্টিয়ারিং গরমাদে বহুত কিছু শিখি কিগেনলে আর দিলের আর আমি অত্যান দিল শরীরে দিলে কান ভালো কথা দিয়ে শিখি আর আরতে আছে হনকান অশান্তি হইলে আর কি করি মানে কি হয় হিয়ান নুবুঝি আর দিলের আর আমি তো অশান্তি আন মানে খেঙ্গলি দাগই খেঙ্গলি শান্তি আনাতা আর পরিবার আমাদের অশান্তি কথা হলে আর কি করি আর আছে ইন শিখি যে নাকি ধরো আত্মীয় অশান্তি হইলে আই নোয়াজ দোয়া করি কোরআন শরীফ পড়ি তো এই গান শুনি পঁয়জা কলরে দল হয় তার হলো গপজম মারি ইন শিখি আর কি কেনলে জিন্দগি সফর যেন নাকি আর মারফটি করতা মরিফানিয়ান জিন্দগি সফর তেনেহলে আর জিন্দগি সফর মধ্যে আর বহুত অশান্তিকর মানে উড়া নিঃস্ব কষ্ট খুশি বহুত লগ পাই কিন্তু একবার খুশি আসছিলাম কিন্তু এখন একটা অশান্তি হয়ে দিই আবারও খুশি আইব আল্লাহতে আবার খুশি দিব কিন্তু ইয়াম বুঝি আর ইন শিখি আর কি কেনলে আর এটা আছে বলা আমাদের সহ্যপথত গইতাম আর মারামারি দিত তো এই আরাতি গুসা বেশি আসছিল কেন আর কাঁ সাপত ছিলেন না আর হঠাৎ দূর গুসা যাবে মাথার আর নবুঝতেন দোয়া কিন্তু হ্যাঁ আল্লাহ বলি আর আছে এটা মিটিং করার ধরিয়া আর নিজে অশান্তি মানে কি হয় দূরে যাই পারি যে নাকি গুসা গজি গুসা জায়গাতে আর লড়ে দেখি পারি
So I'm stopping the video here. I will share the full slide with you, the link with you through the organizers. But I wanted to show this because for me it is so important to show that a volunteer without any training in mental health is actually able to talk meaningfully about quite complex concepts in a way that I think is more effective than when I, as an outside worker, would do that. You see how he blends what he has learned with local cultural knowledge and how it actually, I see the passion and I see this man is effective in transmitting messages to his community. If you wish, there is also an article that he co-wrote with the lady, the Bangladeshi psychologist that you saw in the video. They wrote together about the work that they did. So I will share that too. I think you see the video again, my slides again. Is that correct?
Yes, Peter, yes.
Okay, thank you. How many more minutes do I have? Can I take another 5 minutes?
Yes, please do.
Okay, wonderful. I want to go on this journey through the pyramid. I want now to go from this strengthening community and self-help, helping people help themselves, to the layer where we actually going more about treatment. We talk more about treatment. And there is a lot to say, case management, social work, clinical social worker in particular. But I want to focus on one thing that we've learned over the last 10 years, and that is that it is possible to provide brief evidence-based psychological interventions that are done by non-specialists. With certain caveats, you need to train people, trainings of about a week, 10 days, very competency-oriented, with, and that's very critical, supportive clinical supervision, at least weekly in smaller groups. But if you do that, one psychologist can actually, through the trained para-counselors or counselors, can actually have a much larger reach and have more effect. There is a range of these activities, and this is new. When I started my work 20 years ago in Afghanistan, there was no such thing as these scalable psychological interventions. People did some counseling, but we all did something. Now we have a thorough evidence base. Interpersonal therapy for depression is made into an 8-session model that can be done by non-specialists. We have interventions like Self-Help Plus, which is more like group psychoeducation. We have a range of activities, but Problem Management Plus is actually the one that has become the most widely used. Basically, it is very simple CBT, cognitive behavioral therapy, picking 4 techniques that are well known to many of you, but then tailored in a way that you can teach it very easily to non-specialists. It's about stress management, it's about problem-solving techniques, it's about behavioral activation, particularly for people who are depressed, get them out of that state of being inactive to actually start doing things. So it's actually called start doing, keep going. And fourthly, how you can strengthen psychosocial support in a person who is actually very distressed or has a mental health issue. Now, important here, Problem Management Plus is not meant for a specific mental health condition. It's meant to be transdiagnostic, so you can use it for people with depression, with anxiety, even to some extent for people with PTSD, but also for people who are very distressed and not necessarily have a formal mental health diagnosis. You can do it in individual format, you can do it in groups. It's translated in many languages, adapted in many languages, and it's well researched. It's very well researched. I was part with UNHCR in a research consortium called Strengths, which was about Syrian refugees in 8 countries, both in the Middle East and North Africa, as well as in Europe, with a range of randomized controlled trials. But there are other researches as well. So on the right, you see a summary paper published just last month in World Psychiatry that actually shows, as a meta-analysis, that these activities like Problem Management Plus have a positive effect. Now, we must be honest, the effect sizes are modest. It's not that with 5 sessions of counseling, all mental health problems magically disappear, of course not. But you see overall reduction of symptoms, not in all people, but statistically significant, and I think clinically relevant as well. So let me now move on to the top layer, clinical services. I don't have that much to say, except 2 things. In the settings where we work as UNHCR, we don't have clinical services often when we arrive. So there is no referral mechanism. It's maybe hundreds of kilometers away. There is a psychiatric hospital, and that's not necessarily the place where you want to refer people to. So in these low resource settings, we have to resort to other means. And that is that blue guide that you see here, which is called the MHGAP Humanitarian Intervention Guide, which basically is a crash course in basic mental health for doctors and nurses who should know this, but often in practice don't know. So you can train people in 5 days. That's another example of task sharing approaches, and then enable people in primary health clinics to identify and manage depression, psychosis, epilepsy, and a range of other conditions. Ideally combined with the psychological interventions that I mentioned, like Problem Management Plus. If you combine these 2, you can actually really make a difference, even in desperately low resource settings, such as in Sub-Saharan Africa and in Asia, where we work. Then on the right, you see a recent report from the World Health Organization about the mental health of refugees and migrants. And that's more global. And that actually emphasizes that it's not so much a matter of educating refugees where they can find care, it's actually also a matter of changing that system of care so it's better tailored to the needs of refugees. And you may then have to work with cultural mediators. You may need to train clinical staff in cultural competency. And you sometimes have to make a practical arrangement to facilitate access in terms of transport, in terms of interpretation, etc. That's all. In summary, what I hoped in this very brief talk that you have learned from what I said is, first of all, it's important to integrate mental health considerations in general work with refugees. Secondly, strengthening what people can do themselves in their communities is key, and that can be done from a non-clinical framework. 3, task shifting in psychotherapy is possible and doable, so we should do that. And 4, basic clinical mental health services can be made available even in low resource settings. There is one more thing I want to say about this number 3, this task shifting in psychotherapy. We see now that it's used in the Ukraine refugee response, but we also see that countries like, for example, Switzerland has adopted this problem management plus within their whole asylum system. So they're going to scale it up and say every refugee in a reception center or an asylum seeking center should be able to access that 5-session counseling model. The Netherlands is also going towards that. So this may be something that Ireland could consider if you're not already doing it. That's all. Apologies for talking too long, and I will stop sharing.
No, that was absolutely fine. It was really interesting, Peter. So thank you very much for going through all of that. And at this point, I'd like to welcome back Professor Craig Moran and Safa Kharita for our panel discussion. There's been loads of questions that have come in, so I really hope I'm up to the challenge of sifting through them and getting them out to everybody. So if Craig and Safa would like to turn on your videos there as well. I just need to maximize my own screen so I can see if you're all there. You are, great, thank you. So we're going to start with a question from Molly, because she was straight in there, Craig, when you were just finished. So we'll give her the first question. She found the presentation really interesting and enlightening, and she's wondering, do we know, does racism and or inequality within healthcare come into play in regards to worse outcomes for ethnic minorities?
Yeah, thanks very much, and thanks, Molly. I think it does and can in multiple ways. And maybe just to give one example, which is not so much about sort of direct racism or direct experiences of racism, but more to kind of tie the various talks together and the experience. And I think the key element of this, to my mind, is that when people present to services, and they present to services against the background of the kinds of challenges, difficulties, and traumas that have been described, if mental health services are primarily orientated towards responding to symptoms and to symptom management, then for those populations whose needs are more contextualized within that sort of background, the extent to which those needs are not addressed, and the extent to which services attend primarily to kind of symptoms and so on, it means that what happens is that there's a systematic under consideration of the needs of people from certain populations and certain groups. And this is a kind of example, I think, of how structural and institutional practices work to disadvantage and to misrespond to the needs of some groups relative to other groups. And so for me, the way in which this operates and works is to a certain extent through that mechanism. And then, as some of the data suggests, by not attending to these needs just don't have an impact on the occurrence of mental health problems. They continue to have an ongoing impact on the persistence of these challenges and difficulties over time. And insofar as we don't attend to them, it means that these kind of challenges continue. And so that does lead to worse outcomes, and there's some evidence that suggests it leads to worse outcomes. So I wouldn't so much focus on necessarily is there direct discrimination, but I think some of the ways in which we structure services and the orientation of services in terms of the frame within which we respond is such that it may well be systematically disadvantaging people from minoritized and from migrant and refugee populations.
Okay. There's another question for you there, Craig, about protective factors. Wondering that, you know, within certain populations, do protective factors affect the data and results, for example, strong family links or religion, etc.? And was that considered, or was it primarily negative life experiences impact that was looked at? Also, would be interested in your opinion on unconscious bias with diagnostic criteria leading to more diagnosis within certain communities.
Yeah, so thanks. It's a really important question. So there wasn't a chance to show any of the data, but we do have information and data around some of the sort of potential protective factors that might mitigate the impacts of some of these experiences on risks, and it does have an impact. It does, and it is the case that people who have and have got available to them a range of supports and material resources, then the impacts of these kinds of experiences are mitigated and offset to a certain extent. So that does matter. I think in relation to diagnostic bias and so on, I suspect that does also occur. But I don't think, and I think the evidence sort of bears this out, I don't think that kind of bias is sufficient to explain the findings that we see. And so I think you've probably got two things kind of co-occurring. You do have and do need to attend continually to the ways in which we assess people's needs and problems, and be mindful that the way that we kind of approach and interpret might well distort or misrepresent the kinds and nature of the experiences that people present with, and that's an important consideration. But I think it's also important to recognize and acknowledge that there are higher levels of problems in some populations, and that a greater level of need does occur against a background of challenges which I think services then need to pay attention to. So I think the two probably work together. So it's not, so I wouldn't dismiss diagnostic bias at all, but I don't think it explains what a lot of what we see.
I mean, interestingly, Amelia, on the sort of related question on the flip side of it, I was wondering, is there a risk of underestimation of mental health problems among European migrants due to transnational healthcare that we use? She would feel she sees that on the ground.
Yeah, and thanks very much for that question, because it's a really important one, and I think it's absolutely right. And it comes back to this issue of how we kind of categorize groups, and I think that's also mentioned in the comments. When in the adolescent study that I mentioned, got many more people, 4,000 young people. It meant that we were able to disaggregate ethnicity much more so. And you do indeed find that those kind of populations, traveller communities, for example, do have amongst the worst mental health. But because they're a relatively small proportion of populations, the data on them is very, very rarely available. And so their needs go absolutely under-recognised and under-addressed. And so I think it's a really important point and something that we need to pay a lot more attention to.
Great, thank you. Peter, Linda was in touch there. She really enjoyed your presentation, and she had a question for you that here we go. She was wondering, she finds there isn't much education or support as an Irish psychotherapist on how best to work with refugees and immigrants. And she was wondering, would you recommend any particular outlets to improve knowledge, perhaps the programs you have mentioned in your presentation, or any others that you'd care to recommend?
Yeah, thank you for that question. I need to be a bit cautious because I usually work in low and middle income countries, not in high income countries. So there may be much more out there than we know. There may be courses and trainings and institutes that work on this that I don't know of. But what I would say is, I think the WHO report, I mean, it's a report, but it's a good starting point as well, because it has lots of practical resources. So I would start with the WHO report on the mental health of refugees and migrants. When it comes to practical tools, yes, I'm slightly biased because I'm a bit of a fan of these task sharing approaches. And it doesn't give an answer to all ills, obviously. But I think it could be used as a way to actually provide some basic care and also identify people who are in need of more intensive care. So you could use these interventions not as a standalone intervention, but as a way of a stepped care model, where then also if people are not benefiting from a brief 5-session model can actually be referred, or some people need to be referred in the first place. People with suicidal ideation, psychosis need not to be seen in these programs. So yes, I think it's worthwhile to explore this, and I can give some information through you, Jan, because there are quite some initiatives going on, and there is currently also a mapping going on of people involved in Problem Management Plus globally, and including people who could be involved in training, because there is a whole network of trainers and supervisors that you can tap into. There is by now a large group of Syrian or Arabic-speaking trainers in Problem Management Plus. This could be a great resource to use in Ireland, to have people who could actually train others. So I can share some resources, but that's what I would definitely advise. Thirdly, slightly self-serving, but I think it is important that health providers have, mental health providers in particular, have a good understanding of how different cultural groups that they work with understand and conceptualize mental health issues. So UNHCR has a series of documents on culture, context, and mental health of specific groups. We started with Syrian refugees almost 10 years ago, but we have documents on Somali refugees, on South Sudanese refugees, on Rohingya refugees. And this could be a great starting point as a practitioner working with refugees to read it and to say, okay, and then not to say now I'm a specialist, but to use it as a tool to engage with your clients. It's also about curiosity. Ask them and say, I've heard about this. What do you think? And that may open up discussion. So these are the three things I wanted to say. The WHO report, yes, these scalable psychological interventions, and developing your own cultural competence through these reviews and other documents. Over.
And was there a number of people actually have been in the chat and the questions wondering about training? There's a real appetite for training in these areas. And I'm just wondering, did you mention there the 10-day training psychosocial support?
Yeah.
That's okay, perfect.
It's so even briefer. I think it's even 5 to 7 days. It's called Problem Management Plus, and once I stop talking here, I will put them in the chat if I can. Can I put links in the chat?
In the Q&A, yeah, you should be able to do that.
I will do that, and we'll share it with you as well.
Perfect.
So you can share it with all participants. Yeah.
Thank you very much. Let me see. There's one. Oh, yes, there was another one for you there, Peter. Fiona DC was just wondering, she's making the observation, would it be reasonable to identify point 3 of your list more as psychological first aid as opposed to psychotherapy, which is, a much deeper work that takes years of study?
Yeah. Great question. I would not equate it with psychological first aid, because that's a tool we also very much use, which is, I would say, even lighter, because that's really, you can summarize psychological first aid with 3 words: look, listen, and link. So it's really social work methodology made very simple, which is something we heavily promote in humanitarian settings. Basically, everyone should know that. So whether you are a protection officer, whether you're a reception officer, I think anyone needs to know how to respond to another human being in distress. And sometimes we get so stressed ourselves that we do the wrong things. So this PFA is not so much theory. It's very much doing role plays, seeing that, oh, if I react like this, then actually you think this, and that was not my intention. So it really is about your own attitude and how you respond. I would say these scalable psychological interventions are psychological interventions. They are based on science, and they are based on specific competencies, but broken down in very simple elements, so to say. So, and that, of course, I would never suggest that a training of a week would make you a psychotherapist, or you need 5 years of training. That would be completely ridiculous. So don't worry about that. I would even think that. The question is, can you use evidence-based psychological techniques and have them as a kind of first-line treatment? So I would say it sits between clinical care and psychological first aid.
Okay.
I hope Fiona agrees with me.
Yeah, I'm sure she'll pop in and tell us one or the other maybe in the questions. But that was really, really interesting answer. I've another question or two for you, Craig. But Safa, I just wanted, I mean, really, all of the questions for you, Safa, are more comments of people just sharing how much they enjoyed your presentation, how wonderful they think you are, how generous you've been, how lucky we are to have you in Ireland. All sentiments that I think we probably all echo.
Thank you so much. I appreciate that.
Not at all, not at all. Thank you. But I was wondering as you were speaking, it just struck me as you spoke about, in particular, your mum's almost re-traumatizing by events in Ukraine, and then I'm sure also in Israel and Gaza. And I'm just wondering, do you feel personally, and in terms of your family, if it's okay to ask you this, that you're still sort of in a fight or flight kind of space at this time? Or have you been able to? You are, yeah.
Definitely. Like, we try to forget about it and move on with our lives. Especially that we personally, myself, my siblings have something to do, so we're always busy. We don't really sit down and think about it. But for my parents, they are always thinking about it. So they feel the responsibility, and they miss home. Like, they still not really engaged with society here. They are kind of old people. They've been trying to learn English, but their English didn't really improve that much because it's very hard for them. It's completely the opposite of Arab language. Different letters, the opposite way to write, the opposite way to construct sentence. So it's really hard to them. So they are always sitting down, thinking about home, about other members, and afraid of what's going to happen for us. You know, that feeling like we don't know, especially when you get some sort of events that happening around.
Of course. And I think everybody listening was really struck, everybody based here in Ireland was really struck when you spoke about the events of last Thursday, and how many of us will have watched those and been absolutely horrified. But it's on a completely different level for people who have the lived experience that you and your family share. So I'm sure that was a particularly difficult time, and continues to be. I'm wondering, having joined us this morning and listening to Peter and Craig, have you any questions for them, or did anything strike you in watching their presentations that you'd like to ask them? There's no pressure if there isn't, but I just thought I'd give you the chance if there is.
Actually, I don't have a question, but I really do agree with both their presentation. On scientific level, as a scientist, future scientist, and also on like personal level and experience level, there's a huge points that I was really agreeing with what they both said. And I'd like to thank them both for their hard work.
That's very generous of you. Thank you for that.
Not at all.
There is another question here, Craig, that I'd like to put to you from Shirley. And she was just wondering, you know, she said, could she ask that it seems the labels of psychosis are an added layer to our response to migrants' adverse experiences, and that their reactions are human emotional reactions to higher levels of discrimination that need a more social response. Do you have a thoughts on that?
Yeah, thanks very much. I agree in lots of ways, and I think there are questions that all of this poses, and to kind of approach it slightly scientifically to a degree, but there are questions that this poses about the very nature of what we call psychoses, and I think what a lot of this sort of information and data suggests is that there are various forms and multiple types and manifestations of these types of experiences and so on that we call psychosis. And I very much think that for some people who present with experiences, very distressing experiences of hallucinations, ideas of reference, persecution, and so on, that they occur to such an extent in a context of trauma and adversity and violence that it does make sense to consider and think about these through primarily a social lens, and to think about, to a certain extent, whether the forms of psychosis, or what we call psychosis, that emerge in that context, do they have more in common with experiences and presentations that resemble PTSD and other forms of trauma responses than they do with, for instance, what might stereotypically be considered the sort of hallmarks and characteristics of, say, schizophrenia as a sort of diagnostic group, which might be, you know, presentations that occur against a background of more sort of neurodevelopmental type processes and so on. And of course, we then may be lumping these various things together. And if we lump them together, it means we treat them the same. And it might be that we need different kind of approaches to treatment and so on. And so while it didn't come across in the talk, I actually very much agree with that sentiment. And I do think that we need different lenses through which to kind of view these sorts of challenges.
Great. We've sort of, a number of the questions have sort of intersected, and we've kind of covered a number of people's questions with one. But before we wrap up, I'm just wondering, for both Craig and Peter, it wouldn't be fair for me to not give you the same opportunity I gave Safa. Do either of you have questions for each other? Because I'm conscious people often working in the same area have insights and potential questions that we maybe wouldn't instantly see. So I don't know if either of you, again, no pressure to have one, but just if you did, there's an opportunity to ask.
Well, again, not so much a question, like Safa didn't have a question, but like a remark. But what I really hope, and I think Safa's story made that clear, is that people with a refugee background have so much to offer. And in mental health care, we see that in particular. And it's a sad background. It's a sad backdrop, actually. But what I now see in international humanitarian mental health, I see everywhere the Syrian coming up as trainers for others. So some of our mental health officers we have in Sudan, in Ukraine, are actually in Poland, are people from Syria who went through it all, but were able to transform these experiences in also helping others. And that makes them extremely powerful trainers and supervisors. So we see that now. And these are things that make me happy, that people who actually went through all this are now helping others in quite difficult contexts and actually become the experts. I mean, I often think if we have a trainer who has lived experience, that's really the best trainer you can have.
That's fascinating that that's a trend that you're seeing emerge. As you say, it's depressing that we have to amass a population of people with this lived experience, but really heartening to see that that can be put to good, ultimately their experience, their resilience, that they're able to give others the benefit of that. That's really a really interesting trend to note. I think we're sort of approaching the time that we were going to wrap up. So if nobody else has any other comments to add at this time, I think we'll thank you all. Certainly in the questions and answers, everybody's really enjoyed your presentations, your interaction. It's been really interesting, useful, and valuable to people in terms of their day-to-day work. So Professor Craig Morgan, Dr. Peter Ventervogel, and Safa Kharita, thank you so much for joining us this morning. It's been a real pleasure to chat with you. And for all of our attendees, we're going to take a short break now, but we'll be back in 15 minutes. So that's at 10 to 12, we'll return. Thank you, everybody.
Thanks very much, all. A pleasure.
Thanks.
Welcome back, everybody. And a very warm welcome to anyone joining us now who may not have been with us this morning. So just a few reminders before we get started. We've 3 speakers in this session, all of whom will participate in the panel discussion at the end. So if you do have any questions, you can pop them in the Q&A box. And if you let me know who you'd like them directed to, if there is any one person in particular you'd like to direct your question to. A little later, we'll be hearing from Dr. Caroline Munyi, Women's Health Coordinator at Akidwa, and expert by experience and mental health peer advocate Jennifer Chipa. First, though, to discuss the health framework in theory and practice that's available to people seeking protection here in Ireland, I'd like to welcome CEO of the Irish Refugee Council, Nick Henderson. Good afternoon, Nick. Oh no, it's good morning. It's still the morning, only just.
9 minutes, Jan. How are you? And good morning to everybody. What I'm going to do is I'm going to share my screen and hopefully this works. Just give me 1 second.
That's showing Nick fine. You just need to put into slide view.
Slide view.
Or presentation view, sorry.
There we go. Can we see that?
Yep.
Yeah, okay, fantastic. And I'm going to give myself a little laser pointer as well. So good morning, everybody, and thanks very much to everybody at St. Patrick's for this conference and for the invitation to speak. And just want to sort of, and I was thinking this morning and yesterday about how to say this, but just want to sort of acknowledge how timely an event like this is, and how mental health in our societies is such an important issue. And I think the events of last Thursday, all of what happened on Thursday is relevant to, or there will be an impact on mental health. And so it won't be appropriate to speak to things in particular, but I just think it's important to acknowledge that. So I have approximately 10 minutes to speak, I think, and what I'm going to do is talk about our work as an organization, how we interact with the issue of mental health, what we know about the prevalence of mental health problems with the people that we support. And then I'll talk, and this is the title of the presentation, theory and practice, that what we have in theory, in our law, in terms of the provision of mental health supports and health supports to people seeking protection in Ireland, and then what's available in practice. And I'll also talk a little bit about our work, what's happening right at this moment, and I'll talk about our work in terms of supporting our staff and self-care, vicarious trauma, and then I'm going to conclude with some thoughts and questions for ourselves. So just before I get into what we do, in particular, just a reminder that the asylum process in Ireland is one that somebody has to apply to. So you would come to Ireland, you would apply for international protection or asylum. I will use, and you can use those words interchangeably. Your application will be decided at the International Protection Office. You have an automatic right of one appeal if you're successful. The process currently is taking about 18 months. There's been an attempt made to reduce the time it takes for that decision-making process. And during that time, you're waiting in what's called direct provision accommodation, or also IPAS accommodation, International Protection Accommodation Service accommodation. So in terms of our work, we are a charity that provides services to people seeking asylum in Ireland, and we also do advocacy. But I suppose let's begin with saying what we are not. We're not doctors, we're not psychiatrists. We're certainly not mental health experts by education. We may be mental health people, understanders, if you like. We may have an understanding of the issues around mental health, We are not people with lived experience, apart from some of our staff who would have lived experience. I do not have lived experience, and I want to acknowledge that. So everything I say is through the lens of my work as a CEO here, but also my work as a practitioner in the past. And we're not decision makers. So what do we do? Well, we provide information and support to people seeking asylum. And in the context of mental health and supports, I suppose what the relevance there would be that we are able to try to give to people information in quite a timely manner, that we can, if we're able to answer somebody's question, we can give them information which they can begin to navigate the asylum process with. We can also support them with letter writing, with advocacy, with writing to the government, and so on and so on. And it's through that work, through our information service, that we would engage most of the people that we support, and relationships build up in that work. And there, I think we would be seeing and supporting people through mental health challenges most. And we would also be trying to refer and support people onward to their GP or to other mental health practitioners. We also have a law centre, which is now over 10 years old, and that gives legal representation for people applying for refugee status. Important point there is to remember that that's a client-solicitor relationship, and I'll come to this later on, but that relationship requires us asking our clients information about their past. And that in itself can be very traumatic for somebody. It can resurrect feelings and thoughts about the trauma that they've experienced. But it can be necessary. We have to do that in certain cases in order to win their application. We also do a lot of housing work, and housing is, it's a cornerstone of integration. Without secure accommodation, we find in our work people can face extremely significant challenges and really be unable to begin their new lives in Ireland. So we, just this morning, for example, we have a workshop in our office where we are having some students come in, and we're going to match those students with people we work with to help them try and find housing. But at the bottom line is that it's very difficult to do so, and that stunts people's ability to begin new lives in Ireland. And then we have a lot of, we do education, youth work, and employment. That can be more positive. It's about the future, it's about fulfilling potential, but also remember what I said earlier, is that it depends on status, in that if you don't get refugee status, those things can be stunted. So we've spoken about this already this morning, but just to be aware that there is a huge effects on people's character and personality of trauma, and that we would experience that when working with people. Anxiety, PTSD, depression, sleep problems, these would all be things that we would experience in our work. And we know from our work and from studies that, and this was referenced by the first speaker, we know that it's significantly more likely that people who are refugees or are people seeking asylum here will have PTSD or depression or psychosis, and quite significant rates of depression and PTSD within refugee populations. In our work as an organization, we've built up an understanding of what are, I suppose you call, the stresses on mental health, and they're multiple. And going back to the persecution or experience or ill treatment that somebody may receive in their country, the journey to Europe and to Ireland, people can witness things that are ultimately horrific: loss of life, risk to their own life. People can also experience, and this is a word that we don't use so much anymore, but was a word that was more common in the 80s, and is exile. That idea that somebody is in another country. They may not want to be there, but they're there because they've had to leave their own country and they're exiled from their family, from their home, and from their culture. People can experience culture shock here in our experience, loneliness, and I'll come to the impacts of accommodation and loneliness, poverty. In September, we released a piece of research that we undertook in the summer and the spring, where we interviewed mothers living in direct provision about their experiences and their challenges. And what came from that was a very significant amount of participants felt that they lived in poverty, that the resources that they had were not enough to support themselves and their family. And racism. Racism is prevalent in Irish society. It exists and it has direct impact on people. The asylum claim, as I say, is a process where you have to put forward the reasons why you need asylum, why you fear persecution in your country, and that can require either in writing, before you make your application, in a written questionnaire, or in an interview, that can require you stating exactly what you experienced in your home country, or indeed in your journey to Ireland. And that, in our experience, can resurrect feelings of, that can have been incubated or have been put away in somebody's mind. And certainly when I was a practitioner, as examples, you'd be going into an appointment to take what we would call a personal statement, to take instructions from somebody. You'd have, say, 2 hours or an hour and a half to undertake that appointment, maybe with a break, but it could take a lot more longer than that, because somebody may become upset, they would need a break, they would give more information, they may not be indeed able to continue with the appointment. Accommodation has a huge impact in our experience, and I'll come to this a little bit later. And I say here, or no accommodation, because in the spring, people seeking protection were not accommodated in Ireland, and then this week there was a government statement that may happen again, which is of huge concern to us. People wait for long periods of time. There is a burden of expectation from family members elsewhere, and there's huge amounts of boredom and loneliness. So these are all the things that can affect mental health. These are the tents that were outside Mount Street over the spring. It's lovely sunny weather, but still a very difficult situation. And what I just made reference to was that this week the government announced that they may not be able to accommodate new people seeking asylum, single males in particular, and that's of huge concern to us for physical safety, but also the effect on people's mental health. So just to get to a little bit about the law and the theory and the practice, these are what's called the reception conditions statutory instrument. So this is a piece of law that was introduced by the Irish government in 2018. A few things you may be able to see immediately. There is an obligation on the minister to provide this care. Shall is not, doesn't give any opportunity for the minister not to do so. It's an obligation. Such healthcare as is necessary for the treatment of serious illnesses and mental disorders. So there's a specific duty to support people who are suffering from mental disorders, and where this recipient is vulnerable, such mental health care as is appropriate. The definition of a vulnerable person includes somebody with a mental disorder. So somebody who falls into any one of these categories here on the screen, but including somebody with a mental disorder, would be defined as vulnerable, and then the minister would have an obligation to consider where and in what circumstances they are accommodated in Ireland. And everybody has a duty to have a vulnerability assessment within 30 days of their asylum application. So you should be assessed as to whether you're vulnerable. Vulnerability can include a mental disorder, and if you are assessed as vulnerable, the minister should take that into account in terms of where you are accommodated and in what conditions and circumstances. The reality, so this is what we experience, is that the situation is extremely challenging and has become more challenging in the last 2 years. Existing mental health, and you will all know this as practitioners and service providers, the mental health supports available to people, anybody in Irish society, are extremely stretched. And therefore, in our experience, they are unlikely to be easily accessible by people seeking protection. And indeed, it can be as difficult as accessing simply a GP. There was a period a few weeks ago where GP lists, if there's a system where if you're not able to find a GP, 3 GPs turn you down, you can be referred to assessment by another GP. That system, in fact, just stopped for several weeks. So, and I'll show it to you in a second, or I can show it to you now. You can see here that all these red dots are the centres, the IPAS centres, the direct provision centres around Ireland where people are accommodated. It's very varied. It's in many rural areas, and GP lists may often, in our experience, be busy. And so even if this is the critical part of the presentation, I suppose, is that even if somebody is assessed as vulnerable, it may not necessarily result in a change of circumstances. So when the vulnerability assessment mechanism was introduced in 2018, we had very high hopes for it. It took a while to be introduced, and then assessments began to be made. Sometimes they do have an impact, but sometimes they do not. And we've had to tone down our expectations of the consequence of somebody being assessed as vulnerable. And I also want to acknowledge 2 organizations, Spirassi, which is an Irish charity that supports victims of torture that do amazing and fantastic work, and Cardra, which is an organization that supports ethnic minorities and health, and they do physical health, mental health, and both organizations we would work with, and we do great work, and themselves are under significant demand. So just this is the locations of the centres, but just step back again, just some reflections on the numbers of centres and the numbers of people. 245 centres across Ireland, 26,000 people in those centres, of which 5,500 people are children. So these figures would have hugely increased in the last 18 months. You'll see here 620 international protection applicants are in tents. That figure has gone up. These statistics were of the 26th of November. The last time I looked at that figure was about 2 weeks ago, and it was 400 people in tents, or 430. So what we have is more buried centres in more remote parts of the country, deteriorating conditions to the point where some people are in tents or even not accommodated at all, and also significant numbers of children. Looking back to the spring, and as I say, what's happened this week, we do have great concerns about the idea of people being homeless. And this report that we did in June, it spoke to people who were homeless, and people spoke about the challenges to their mental health, the consequences of on their mental health, the isolation that they felt, and their threat to their physical safety. But, and I suppose this is the big but of my presentation, it's been mentioned by others in the morning, we really always try to remember that the people that we work with are people of great resilience. We would always try to not automatically define people as vulnerable. They may be in vulnerable situations, but people have incredible potential, capacity, resilience, and we need to acknowledge that, and we need to assist people to move on. So we do have some projects we had that particularly working with young people. So in over the last 2 years, we've had 2 projects, Move Your Mood and Mind Yourself. Move Your Mood worked with young people. We did it over the summer, and that's where the power of physical activity to impact and improve somebody's mental health. And we worked with Ajiro and Laprid, 2 fantastic well-being experts and mental health experts and dancers that worked with young people. And then we also produced this comic several years ago. We still have copies. We still have physical copies in the office, actually, if anyone would like one. And it's a resource written by young people to assist people in the asylum process about the mental health challenges that they face. So I have 2 more slides to go, and I think I'm already over time, but I just want to finish on this. One thing that we've tried to develop in recent years is the idea of self-care and supervision. I began doing this work in 2004. I worked in London doing asylum appeals for people seeking asylum for about 6 years. And the idea of self-care and supervision then was literally going to the pub on the Friday afternoon and talking about the cases. That's no longer acceptable. I believe as an employer, we should be proactively supporting our employees. So over the last 2 years here, we've made 2 changes. We bring in a expert employee assistance program delivered by the Clanwilliam Institute. So it's confidential and specialist support. And we also do a group supervision around every 2 months. It was actually happening just now in our office next door. And that's where one of the Clanwilliam staff comes in and talks to our staff in a group format. And it's important, I think, to do this. We would hear and people talking about very extreme situations, displaying difficult behavior. I myself has witnessed somebody self-harm in our office. So it's important that as an organization, we support our staff, and also to remember that the best advocates can be those that are dispassionate, and that doesn't mean that you're not focused on your work. It just means that you're able to focus objectively on supporting the person in the process to the best of your ability, with the aim of getting them refugee status, and particularly in the legal representation context. That was really and is really important, that we can step aside, that we are professionals that are working to an aim of getting that person protection in Ireland. So just a few thoughts from me before we finish. It's mental health supports. The work of St. Patrick's and other organizations is so important, and we need financial investment. We need to increase our understanding of mental health in society, and we need to increase access. There is a significant gap between the law and the reality, the law and practice in terms of mental health provision and people seeking asylum. But the law is strong, and we would hope for a better day in a period of less crisis where those services could be delivered as they are needed. There's a growing move towards positive and reflective self-care for service providers. This does require resources in and of itself. We've developed a budget for this. And then I suppose, finally, that there are huge stresses, there's huge challenges, but there is also huge resilience. And huge agency, and that we have to, as an organization, recognize our own privilege and support people in this process. And I want to just show you two pictures of our youth work. Our youth work gives us great energy, working with amazing young people. 2 projects, one in the Connemara 2 years ago, and one just this summer, that I think demonstrate the sort of the forward-looking nature of the people we work with, that they are here in Ireland to begin new lives because they have come from something much worse. And we are in awe, and we are privileged to work with them. So just 2 pictures that I think demonstrate that. And finally, just a few resources that we offer. We have something called the Asylum Support Network, which works with organizations. So if you're interested in joining that, and we also have housing education guides in our helpline. So I'm well over time. I want to stop there, and I hope that was useful and interesting, and looking forward to the panel. So thank you.
Thank you, Nick, and no worries about the time. And thanks for ending on those images. They're really, really positive looking images, you know, to focus on. As you say, the outward looking is great. And I'm really glad you mentioned self-care, because it was definitely something, listening to Peter in particular talking about visiting refugee camps and putting, you know, you do wonder, how is the individual's own self-resource going to remain intact if there isn't space for self-care? So thank you for mentioning that. That's important too. I know you're going to join us later for the panel discussion, so we'll let you off now and move on to our next guest, who is going to focus on mental health among migrant women. I'm delighted to welcome Dr. Caroline Munye, who's Women's Health Coordinator at Akidwa, an organisation which, if you're not familiar with it, works to create a just society where all women have equal opportunities and access to resources in every aspect of life. A mission I think we can all get behind. So good afternoon to you, Caroline.
Yeah, thank you very much, Jan. And so my name is Caroline, and you've just been told that I work for Akidwa, the Migrant Women's Network. And what we do is that we work closely with women and who are in the community, as well as in the direct provision centers. Akidwa was started over 20 years ago just to focus on issues which the migrant women were presenting then, and one of them was isolation. And they are still isolated as we speak, and you'll see why. So maybe we can move to the next slide. So Akidwa's approach to mental health, we've done research, and this research, the most important one was done in 2019. And if you remember 2019, towards the end around October there, that was way before, that was way before COVID, not way before, but before COVID. And we launched that research. It's called Let's Talk in January of 2020. And then COVID hit Ireland. And then, as you remember, there was all this talk about mental health, people talking about it in public, in private, and which was good. But one thing I want to say that Akidwa was already aware of the mental health among migrant women through that research. And some of the things the women talked about was huge stigma. And because that obviously we could see their lived experiences, and then they were able to name them, what was happening in the DPs and to them, and some of the things they can and they cannot do. And how their world and sometimes for many women today in Ireland, especially migrant women, their world is still very, very small. So the issue of stigma was huge, because most of the women where they come from, and even where I come from in Kenya, we do not have a word for mental health, like especially when it's failing. And sometimes there may also be the language is also lacking around seeking supports like counseling, because like what I used to see even my mother doing another women is just women sitting together and talking among themselves about what's going on, and even maybe to their children, maybe a husband or anything. But hearing someone is going to seek special ed support, it's huge, because sometimes it's because something has gone very, very wrong, and this person has become cuckoo, and then that person is pushed farther and farther, not realizing that sometimes it's not just that there are other issues. And so that was mentioned by the women, how about the issue of stigma, and so they don't want to talk, and because of that, their world has become very, very small, and then there are other consequences because of not opening up to what's going on. And so because of this not speaking, it increases, and it's increasing their vulnerability, become more and more vulnerable, because the fact that you're not saying anything about it does not mean it's not happening, or it's going to disappear. It is there. And so the issue of stigma, and so we'll see why in the next and last slide, where maybe I'm going to dwell more now on other issues like targeted interventions and wraparound supports. And how do we do this? There's no way someone will come to you and tell you maybe they have nowhere to sleep. Maybe a child is having issues in school because maybe of racism, other things. Maybe the teacher is saying, I cannot understand what you're saying, or maybe this child has a lot of issues, or they are always having problems. And maybe where you're staying, maybe the room is very, very small, and there you have your children, or 2 or 3, your husband, and that's why you're doing everything imaginable and unimaginable. And then the same person will tell you maybe in the streets they're having issues, maybe they're being called names, even just before even what happened last week. For some people, that's how they live, even when they are walking. And sometimes it's also unexpected. You just hear a name has been dropped, maybe because of how you look. And so someone is telling you all these things. They have no money. They don't have this. Maybe someone is also unwell at the same time. So it's up to you as a practitioner to figure out and know that this person could also be needing maybe a few mental health supports. And this is now maybe through careful interrogation, like, how are you feeling? Then this someone will tell you, I feel like this. And the same person might even cry because of what they're going through, but someone will never say that they're having a mental health crisis. So it's up to you to figure out. And that's now where the wraparound supports come in. Because some women do not say, although the food is not there, they will not say that they need that. So it's up to you maybe to figure out, like, where's the nearest food bank? Maybe you can make a phone call. As you make a call, maybe to other organizations, maybe offering accommodation. We also said some people even to NICS organization, to IRC, and as part of the referral process. So it's up to you to figure out. And then as we encourage women along this journey of let's talk, because now after the research, now we created those openings that we need to talk without saying that it's mental health, because the word mental health is going to say that the women are scampering for safety, because just that word alone, but we call it let's talk. So it's still there. And so among even asylum seekers, the situation is the service providers. Now we've started now bringing service providers together and talking about cultural competence which they need so that they can be able to help the women who are coming from we're in the DPs and coming from certain backgrounds, so that they can be well understood. And even we have like we have associations with the therapists who are culturally very, very culturally competent to deal with this. We will know how to navigate sensitive issues and to encourage people to speak and then take them through a journey of feeling much better and gaining energy and strength to be able to move on and to be able to acquire some skills to navigate life. And then at policy level, we are also advocating, and our Let's Talk research has been a huge eye opener. And so I'll just give you one very, very small case study, and that case study is something I'm just going to tell you, and it's not here in a slide, and that because sometimes that's how because I just want you to get a taster of how what it means sometimes to be vulnerable, and how then some words around mental health for people coming from certain cultures are difficult. So we had this person who used to come to us, and I'll call that person maybe Jay, and we worked with that person before COVID and through COVID, because there are a lot of things which are going on, as Nick was saying. And so at the end of it, at one point, the person was very, very out of herself. And I remember even telling my boss, because I'm the only one who used to go to the office, because I used to live near Dublin then. And I was telling people that I'm one of those people who never learned how to work from home. Because during COVID, when people were working from home, I always used to go to the office because of that proximity and other factors. And so Jay would come to the office, and I remember one day she came and she was running and she was like, open for me. She was calling me Caroline, open for me. So I opened for her, and she was in bits. She was in proper. She was completely out of kilter. So I called other people to try to help. And we were able to get for someone to sleep for the night, and also someone maybe to keep on calling. And we embarked on this journey, and it was not easy, because I remember one day a member of our board said, Karen, you need to protect yourself because that situation is not going well. And so it was very, very tough for Jay. And So she came out on the other side, and I remember the day she got a place to live, our own house, a key to our own door. She came to the office and she was so happy. And she was like, Karen, even I'm going to cook for you today. And one time she told me, actually, I'll come and pick you from the office and take you to your home because I want to do something nice for you. Obviously, I know how to, I know how to deal with that. And then she told me something else. If you ever need somebody to talk about the work you do, let me know and I'll talk about it. And because of the support you've granted me. So one time we got a phone call and somebody wanted someone to talk about, and this is now being connected with what you're doing today, to talk, she wanted a service user. And I recommended her and gave her number. And so just sitting in the office and Jay called me and again with a very, very friendly voice. And she told me, Caroline, yes. Do you remember that time I used to sleep at the airport because I had no accommodation? I said, yes, I remember. And then she went to the next question. Do you remember this time when I used to come to the office and I told you, help me or I die? And I said, yes, I do remember. Then the next question was, do you remember when I had no house, no nothing, and even I wanted to beat you up? I said, yes, I will not forget that. She told me, I have gone through all those things. I've been very, very depressed in my life, but I've never suffered from mental health. And so I aired there. So like that, sometimes that's how intense things can get. And even the wording and all that. So sometimes it's up to us to be culturally competent and know how to navigate this. Obviously, the impacts on us, as Nick has said, and so like we need those supports for self-care and all that, but also to know the language and to seek culturally appropriate language and know how to navigate delicate and sensitive issues. Because I know even today I still get people requesting me, can you give us a service user? And these days I decline to do that. And so thank you very much for having us, and thank you. I end there.
Thank you, Caroline. And that's a really, being culturally competent, yeah, that's a really interesting idea for us to maybe chat a little bit more about in our panel discussion, which I know you'll be joining us for. So we look forward to chatting to you again then. Now, our final speaker of today, for this presentation, we're returning to the importance of sharing lived experience, which clearly from the Q&A you all found so valuable in the first session. So we're returning to that, and I'm delighted to welcome expert by experience, mental health peer advocate, Jennifer Chipa. Good afternoon to you, Jennifer. Thanks so much for joining us.
Good afternoon, everybody. My name is Jennifer Chipa, original from Zimbabwe. I'm going to talk about practicing resilience. When I immigrated to Ireland, which I now call home, living in a direct provision, I was stressed and poor mental health, physical and well-being. I was traumatized, depressed and vulnerable. I decided to pursue my studies in mental health to understand better what I was going through and what I can do about myself, and to grant me a unique perspective to guide others going through adversity. I did a specialized training for immigrants with COGIA, Pathways to Wellbeing. And I learned about migrants' mental health and supporting immigrants and ethnic minorities. I joined a training program as a peer mental health advocate with COGIA. These trainings had an impact on my life in a positive way. I learned about different stress, types of resilience, and how to handle them. I now know my personality and I understand my personality in a key resilience. I gained more strength, courage, confidence, and I was able to work through my own traumas, fears, using resilience techniques I learned. But then I realized something. It wasn't about waiting for the storm to pass. It was about learning to dance in the rain. That is what resilience is all about. It's about bouncing back from hardship, picking yourself up after a fall, moving forward no matter what. Practicing resilience has helped me to uncover my strength I never knew I possess. It has taught me that I'm stronger and tougher than I gave myself credit. Trust me, developing resilience can do the same to you. It can help you to discover your hidden potential and show you what you are capable of handling, what life throws your way. Today, I volunteer with Koja as a mental health peer advocate. Furthermore, I am a certified mental health well-being coach in private and a speaker, passionate about helping women to develop resilience. Thank you.
Thank you, Jennifer. Thank you very much. That was really interesting, and I'm so impressed at people's response to trauma is often to learn and to educate themselves, and the amount of self-education and improvement you've undertaken in terms of your course on resilience and then sharing that with others is really impressive. So I really appreciate you sharing that with us. Thank you for that. And at this point, I'd like to welcome back Caroline and Nick for a panel discussion so we can have some conversations. I'm just going to go into the questions and answers. Now, I'm not sure if Caroline, oh, you are able to join us, Caroline, great. If you need to leave, we totally understand, so don't worry. Actually, I may ask you the first question, Caroline, in case you do have to leave. So Fiona, one of our attendees, has said that what she understood from your presentation was perhaps the importance of meeting the person where they're at and understanding the language they use is enough for us as practitioners to work towards appreciating their circumstances while respecting the cultural perspectives around mental health. Would you share that view?
Yes, it's about understanding and going to the level where the person is, and also willingness to learn, because that experience in my with our service user, like we really had to sit down as an organization, and I was like, let's go back. We need to take a step back, you know, and it's not that the service is still very, very close to us. She comes and she still cooks for the organization and all that. But it was about the need to take a step back about the language and the emphasis of, meeting people where they are and also willing to learn from them because even of how they perceive their situation. Because you might be thinking that this person is so vulnerable because she was like this, but maybe they were looking at it from a very, very different perspective.
Yeah. And of course, we don't always meet people fitting into the frameworks that we have sort of learned to categorize them by. So
we have to box them, and so like it's also about that. There was so much to learn, even for me, and like it was huge.
Good. I'm just conscious this is less sort of a question specifically for anybody, but it's just a sort of a number of things that came into the Q&A related to the presentation from Peter Ventevogel earlier. Shirley was saying that she found his approach a really inspirational one and had wondered, was that psychosocial model presented to the Irish government as a potential model? And then Dr. Niamh Marinan has been in touch to say, just in relation to that there is a HSC psychosocial response for refugees and applicants seeking protection. And this is the model of care to meet the need in collaboration with the National Social Inclusion and Mental Health Offices. Now, she herself is psychosocial lead in the Dublin Wicklow area, and she's just had a senior psychologist join her with funding provided by way of this. So it works to a sort of a layered care support framework based on the work that Peter described. So that sounds positive, Shirley, in terms of what you were wondering. She also, Dr. Niamh Marinan, also flagged a document available on the HSC website that was put together by the Psychological Society of Ireland, and it's called Understanding Trauma and Supporting the Needs of People Fleeing War or Persecution. That's Understanding Trauma and Supporting the Needs of People Fleeing War or Persecution, available on the HSC website, along with some other resources. So many of our attendees may find that useful and interesting to engage with. So I just wanted to put that in there. Now it's funny, I have a question here for Nick from Fiona that I think may have come in at a certain point in your presentation, Nick, and then you kind of went on to say something similar yourself. But basically she was saying, I wonder whether the word vulnerable is doing a disservice to refugees and asylum seekers, as surely by the nature of their circumstance, they are all universally vulnerable, and therefore a more effective word to represent the immediacy and urgency for specific subgroups might be worth considering. Not sure what that better word might be right now. But I think you sort of went on to say that in your presentation yourself around it's not so much individuals' vulnerability as the circumstances they find themselves in.
Yeah, there's quite a bit of work done on quite a lot of criticism and critiques of that word, in that we say, for example, we as an organization would say Jan is a vulnerable person, and Jan could be, may not want to have that label, may not necessarily be vulnerable, may only be vulnerable as we define it for a short period of time. So we would try to use that phrase in a vulnerable situation more. Nevertheless, if you look through as my presentation, I probably said it in my presentation, and you'd see it in our work and communications, we would use that word quite a lot because it's the one that we have in law, it's within our vernacular, and ultimately there are quite a significant number of people who are in very difficult circumstances and very difficult backgrounds. So it's certainly imperfect. We probably need both a better word or an additional word, and there is ethics around the use of the word as well. But like everything at the moment, it seems, you know, if we use the word vulnerable a lot, we use the word crisis even more. And so in times of crisis, where things are often imperfect, but it's a really interesting debate about the word. For example, we're trying to develop a new strategic plan. We've included the word vulnerable, and a board member pointed it out to us and said, why are you using that word, for example?
Well, actually, Fiona has just clarified there. I misinterpreted. She was saying her comment on the word vulnerable, excuse me, was in response to how it was framed in law, as you mentioned there, most specifically.
Yeah.
But it's interesting when Fiona mentioned it, and equally when you mentioned it in your presentation, and then you went on to describe how stretched services are and you know, the compounding issues. It struck me that somebody may not be vulnerable and may be in a vulnerable setting, and we may push them towards vulnerability themselves through having to constantly hit their head against a brick wall.
Yeah, indeed. And we would have worked, and just to acknowledge what I think it's Neve said, Dr. Marinan,
yes.
Marinan said around, you know, there is what I hope you didn't leave my presentation with the belief that there is no services. There is, and they're doing great work. It's just that they're I don't want to speak on their behalf, but they're stretched, and they need resources. Like all our healthcare and all our mental health care needs resourcing and support. Just remind me what you said there, Jan. I was just the second part of your question.
I had basically just been wondering, as the word vulnerable had come up a few times, that we were talking about individuals' vulnerability, and perhaps they weren't necessarily vulnerable individually. So, do we push them towards that?
Yeah, well, we would have definitely. Yeah, we would have definitely experienced that working with young people, or and it doesn't really matter in terms of age. Anybody who'd arrive at a certain point, but then regress. Now, there has been changes in the asylum procedure here in recent years that I wouldn't say have alleviated that, but things like the right to work gave people the opportunity to do something. Boredom was a huge issue, a long asylum process with huge delays where you couldn't work. Living in poor conditions is a really bad recipe. The right to work has been negatively balanced out by other things. There's now quite long delays in applying for work and so on. but yeah, that's certainly a phenomenon we've observed, that people can regress. Not everybody, but people can regress, certainly.
Mm. No, and just to reassure you, I don't think you did give the impression that there were no services. It was more Niamh was responding to a question from Shirley relating to a previous speaker's conversation around psychosocial interventions and templates and things. So no, you didn't give that impression at all. You were simply,
Jan, how would I post a comment to everybody? I've just got a sort of map of resources, an online Google map of resources that participants might want to access.
If you want to actually just stick it in the Q&A box, it will appear there. Like, it's not a question, but it will appear there, and everybody should be able to see it. So thanks for that. That will be really useful. I'm just scrolling through these.
Oh yeah, I see that now.
That's an interesting one there from Grania as well, is wondering how much is language a barrier to accessing services, mental health services, and if, you know, what are the supports like in that area? I mean, I'm imagining they're probably stretched, but
yeah, most definitely. Most definitely. And one thing that we did in the spring, which was really useful, really impactful, was that during the homelessness crisis, we did a fundraiser for extra capacity, and we hired a Dari speaker, somebody from Afghanistan who spoke Dari and Pashto, and we worked directly with people. She was able to work with people via her language, and that was really interesting. In some ways, she said that people were speaking to her in a different way as to which they would speak to a caseworker. They may give more information. They would feel less restrained, more obviously easier to communicate when you're communicating in your first language. But then, yeah, ultimately the big barrier would be, how can you access a mental health service or mental health supports if there's a language barrier? So yeah, it's a huge issue, and there'll be organizations, Intercultural Language Service in Dublin, Fulcher Stock do great work around language and so forth, but again, quite stretched.
I'll bring you in a sec, Jennifer, but I just wanted to quickly ask you, Nick, I'm not sure if you have an answer to this, but somebody's wondering here, apart from, you know, documents, reports, these kinds of things, are you aware of any relevant training in Ireland for psychotherapists, for example, to attend around cultural sensitivity, language, just clients in that cohort generally?
Yeah, we would provide some cultural orientation and bias training. It's not necessarily in the context of or for people working in the mental health field. There would be some other resources as well. What I could do is just have a think of them, and then if you're going to, I could come back. But it's a great question, and I could come back to you, and then we could send it on to the Adele and other people who may be interested.
Okay, that would be great. Yeah, if you
and if I think of anything, and I've just popped in the chat there. I don't know if you can see it, a map that we have, an online map of resources, and I see that there's Angie's got a recommendation that looks really interesting as well.
Yes, I think you answered Gronia's question with the map.
With the map.
So people can find that in there, which is great. And yes, Angie, I'm laughing with your shameless self-promotion. That's okay, Angie. Just talking about being trainers and consultants for mental health professionals in the area of diversity, including displaced people, psychologists, family therapists, and that's PARC training. So that's interesting. People can see that there in the Q&A. Now, Blessing, hi, how are you? I see a question from you, and I think you were involved in Founders Day last year, so it's great to see you back. Blessing has a question really for anyone. Jennifer, if you're still there, it would be great to get your take of this as well. She's wondering, in terms of the ongoing circumstances in Israel and Gaza, have you any awareness of any ongoing outreach initiatives or funding for support groups or mental health therapies for the migrant diaspora resulting from that? And if that's something, it's something that's come up often in my youth and community work, but haven't seen anything and wanted to ask here in case Hope this makes sense. So, yes, so sorry, Blessing, I misinterpreted that. It's for the Palestinian Irish community. If we're, I don't know, Nick or Jennifer, I'm not actually sure if either of you would know off the top of your heads if there is any ongoing outreach initiatives for that community.
I don't know. Jennifer, do you mind?
Yes, COGIA is helping some of the people from Palestine and Gaza. What's going on with this? All the what is going on with people? They have vulnerability and what's going on in the war. Some of these people traumatized and they are stressed. So COGIA is trying to help some of these people in Gaza.
COGIA.
Yes,
okay,
COGIA,
that's
yes.
great. That's great to have. And actually, it's an interesting point that Blessing mentions, and also Safa alluded to earlier. The idea that even when you have fled someplace and you've set up a life someplace else, you continue to have family in that place, you have your own community in that place, and ongoing worries and concerns when there is either war, humanitarian crises, unrest. Have you experienced that, Jennifer?
Not personally, but I've got some people who have gone through experience those things. And also with their mental health Europe task force, I'm also a member of the European Immigrants. So we are doing everything in our capacity to help all the immigrants.
Yeah, it's much as today has been a really, really interesting series of conversations and presentations, and our attendees have been great at being really engaged and answering brilliant questions. It is really stark to think about how Safa's experience from Syria, speaking about then when war begins in Ukraine, how that impacts her and her family, worrying, and again then the situation currently in Israel and Gaza. It's really, it's kind of I don't want in any way to end on a intensely negative note, but it's stark to see that these cycles continue and potentially re-traumatize people who've been through these experiences in the past. That's not really a question so much as just an observation that occurred, possibly an unhelpful one.
And I think that's what I was trying to get to with the word around exile, is that everything that is dear to you is now not in your reach and is indeed possibly being destroyed. And you can't do that much, probably nothing about it. And that's a wretched human experience. I imagine, I don't live it, but from our work, we see it, and it's wretched and it's terrible. But that's why we should support people to support themselves or build lives in our professional work.
Sure. And in terms of supporting that professional work, Nick, and for you too, Jennifer, in supporting the work that you're doing, is there a particular, everybody hates this question because nothing can be reduced down to one thing or a top three things, of course, but is there an overriding thing that you feel this is actually, if we could sort this might be the key to unlocking a lot of the other supports?
As for me, as a mental health peer advocates, it's for us to help them, support them, encourage them, and give them hope.
Yeah.
That is what we can do. So I just think if we can have more trained mental health peer support, be able to support everybody, just because now Ireland has got so many immigrants and they've got few mental health peer advocates. So if we can have more people trained so they can help everybody. And also we can have people trained peer mental health support, peer advocates from all different nations who can speak their languages. So sometimes there's this language barrier. So sometimes I don't understand each other. So we need people who can also from their countries or who can speak different languages. They can be able to help them as a mental health peer support.
And that certainly came across earlier in some of our other presentations, just the value of having somebody, even in, as you say, Nick, the most wretched circumstances, to just stand alongside you and allow you to be heard. We can't underestimate the impact and the value of that. Yeah.
So even having an interpreter is different from somebody who can speak their direct language. Interpreter goes on the tail, they won't be able to express themselves. And that interpreter cannot be able to express exactly what this person has said. So they need somebody who can speak their language. They can be able to engage and interrupt and talk to each other what's going on.
No, that's a point well made for sure, Jennifer. What about you, Nick? Anything that occurs to you?
Well, I think Jennifer's point is so important, and it has significant advantages, not least because it allows for direct communication without an interpreter or a third party. There's a mutual understanding because of shared lived experience. It allows for scale. It can make not universalize access, but it can increase access. So I think and I think Peter mentioned this in his presentation as well. So it's certainly a theme that's emerging this morning. And then I suppose you do need the structure to support that. You would need an organization to like Cadre or another organization who has to give them the resources to build this sort of network. Stuff like this it needs investment and infrastructure, and then it can bloom and grow, but it does need that support to begin with.
Sure. Well, on that note, I'm going to thank both of you and Caroline, who had to leave us unfortunately, but thank you, Nick, and thank you, Jennifer, for giving us your time and your experience and your expertise. Clearly from the Q&A and the chat, people really appreciated it and really got a lot out of it. So thank you so much for that. And, take care, and we'll hopefully see you at something again in the future. Bye. Thanks,
Thank you, everybody. Bye.
Now, just I'm going to invite Professor Fearon to join us now, as we've effectively reached the end of our event in terms of our chats and our presentations. So, Professor Fearon, if you'd like to come back to us and just share some of your observations on the day. I mean, certainly it seems people found it really valuable and useful. So if you'd like to share some of your thoughts as we
I'd love to, Jan. Can somebody enable my video? I have sound, but here we go. Super. So I'll just share a few brief thoughts before we go. It's a really interesting experience preparing for Founders Day. The Founders Day Committee are preparing it for months in advance, but there's something particularly special about when the day happens and it all comes together. And I suppose particularly this year, I found it a very moving experience, as I'm sure I wasn't alone in that. I mean, I think if the events of the last 10 days in Dublin, particularly that night, that last Thursday week, if there's anything positive to come from it, it's that we can't take things for granted, that we have a shared humanity, and we can't just, if we've lost a little bit of innocence, maybe it's for the good, that we need to look after each other, that we all share this little speck of cosmic dust, and we're only here for a blink of an eye in real terms, and that the thing we have in common that bonds us is our human experience, regardless of what part of the world we're from, and we need to protect each other, be kind to each other, treat each other with dignity and respect. And I think that came through in all of today's presentations. I make a few points of thanks to everybody in no particular order, but and I'm sure as always I'll leave a few people out. I'd like to thank Jan as always for moderating and holding the day together so well as always. Thank you very much, Jan. It's always a pleasure to work with you. I'd like to thank members of our Founders Day Committee who worked tirelessly in the background, Tamara, Sinead, Katie, Orla and others. The amount of work that goes into a day like today is immense. I'd like to thank all of our speakers, obviously, but one of the things that we made a conscious decision about a few years ago was we wanted to really increase and have meaningful representation from either service users or people with lived experience. And I think you'd all agree that Jennifer's and Safa's contributions today really added. I mean, they were essential contributions to the day. It added context and a real sense of what this is about. So I'd particularly like to thank Jennifer and Safa. Thank you both very much indeed. I don't think I've anything more to say other than to thank you all for coming along, and particularly for your questions and comments, and for the lively session we've had today. And I'll leave it just to look forward to welcoming you all back to next year's Founders Day. Thank you all very much.
Thank you very much, Paul. And I think everybody would echo those sentiments. The lived experience components of the day really shone through and just helped to give real context to the other presentations, which were equally excellent. Just one thing before, I'm just conscious here, Edel, I see your question about research, and I think if you email communications@stpatricks.ie, one of the members of the team there might be able to point you in some directions after the presentation today or in the coming weeks. So I hope that's okay. Sorry, I just didn't see it in time to put it to our contributors, so sorry about that. All right, that is the end of our event today. A reminder that your CPD points and, it's to thank you and to remind you that there are CPD points for today. And if you go onto your relevant association, you'll be able to access those there. General attendance sheets will also, or certificates will also be sent out if you requested them at some point in the next probably 4 to 6 weeks. A recording of today's conference is going to be available to everybody and on the stpatricks.ie website over the coming weeks. If you think any of your colleagues might benefit from watching it or they might have an interest, you can share it with them. And just to say, your feedback is actually really important, because the team at St. Patrick's, as Paul outlined, put a lot of time and effort into organizing these events and, getting contributors that are going to give, really interesting and relevant content to you. So your feedback is really helpful for them in terms of building future events and resources. So when you finish today, a little link will pop up with a feedback form. It's not a long one. It just takes a wee while to fill out. If you wouldn't mind doing that, that would be massively beneficial to everybody. And with that, just thank you very much for joining us. It's been a really interesting morning and early afternoon. And I hope you have a really great rest of your day and weekend. And take care, everybody. Thank you.